Bu Juana, suara saya kedengaran, Bu? Oh iya. Boleh kasih jempol Bapak Ibu kalau suara saya kedengaran? Oke, thank you Bu Juana. Baik. Ladies and gentlemen, we will start our international conference. Opening ceremony, 4th International Seminar of Medan Health Polytechnic of Ministry of Health with the theme Development of Maternal and Child Health Services in Primary Care Integrations, October 21st until 22nd, 2025. Ladies and gentlemen, before we start our opening ceremony, let me read some poems or pantun in Indonesia. And would you mind to give me checkup or grade maybe, or with emoticons from the Zoom mode chat. Mentari pagi bersinar terang, bunga mekar harum baunya. Ilmu berkembang, wawasan merangkum, hadir bersama di forum mulia. Let me translate in English. The morning sun shines brightly, flowers bloom with fragrant scents. Knowledge develops, insight summarizes, present together in a noble forum. Ladies and gentlemen, ketika saya sapa Bapak Ibu dengan semangat pagi, boleh Bapak Ibu berikan saya mungkin cakep, semangat luar biasa, atau mungkin dengan beberapa emoticon yang tersedia di Zoom room meeting kita hari ini. Semangat pagi, luar biasa, tetap semangat. Or you can ask me in English, please. When I say to all of you, morning spirit, morning, you can answer my greetings with extraordinary, keep it up, fighting. Extraordinary, keep it fighting. Good morning, ladies and gentlemen. Extraordinary, keep it up, fighting. Thank you, ladies and gentlemen, for the greetings. Happy ladies and gentlemen, healthy greetings, good morning and best wishes for all of us. Praise and gratitude we pray to the presence of God Almighty, because on this day we are still given favors and health to carry out the opening ceremony, the 4th International Seminar of Medan Health Polytechnic of Ministry of Health 2025. With the theme Development of Maternal and Child Health Services in Primary Care Integrations. I'm Hannah, and I'm honored to serve you as the Master of Ceremony today. And ladies and gentlemen, this conference brings together global experts, policymakers, and practitioners to explore innovative strategies for strengthening maternal and child health through integrated primary care systems. The Honorable Esteemed General Directors of Health Workforce of the Ministry of Health, Ibu Dr. Yuli Varianti, M.Epid, the Honorable Executive Officer of Director of Medan Health Polytechnic of Ministry of Health, Ibu Tengku Sriwayuni, SSIT, MKEP, all Deputy Directors of Medan Health Polytechnic of Ministry of Health, all distinguished speakers, our respected keynote speakers today, Professor Dr. Adang Bahtiar, MPH, DSc from Indonesia, Dr. Nola A. Holness from Florida, United States of America, Miss Ethel May Faigo Onas, RND, PhD from Philippines, Dr. Haslina Mukhtar Ajaimer from Malaysia, Dr. Fitri Widyaningsi, MS PhD from Indonesia, Miss Midori Anami Akimoto, PhD from WHO, WPRO, Ibu Masra SPD MKes from Indonesia, and Mr. Dr. Haripinto Gapsinaga, MCN from Indonesia. The Honorable Head of General Administration and Students Affairs, Head of Department and Study Program from Medan Health Polytechnic of Ministry of Health, managers in Medan Health Polytechnic of Ministry of Health, all committees, all the esteemed speakers and reviewers joining us today, dedicated lecturers, researchers, clinical practitioners, and students, and all participants in this international seminar. Ladies and gentlemen, the opening ceremony of the 4th International Seminar of Medan Health Polytechnic of Ministry of Health today will immediately begin soon with the agenda. First, introductions. Second, singing the national anthem Indonesia Raya, Mars and Hymn Medan Health Polytechnic of Ministry of Health by all attendees. Third, prayer led by Mr. Muhammad Arsyad Eskom. And the fourth, welcome speech and opening remarks from our Executive Officer of Directors. And the next is discussion, documentation, and material delivery for all our distinguished speakers today. So ladies and gentlemen, we move to the first agenda. We will sing the national anthem Indonesia Raya, Mars and Hymn of Health Polytechnic of Ministry of Health of all attendees. We ask you to take a respectful position. Ladies and gentlemen, as a thanksgiving and so this event gets the blessing from God Almighty, let us start the event with the prayer, which will be led by Mr. Muhammad Arsyad Eskom. To Mr. Muhammad Arsyad Eskom, time and place are welcomed.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, all of us. Before we start this event, let us pray according to our respective religion and belief. Let me lead the prayer according to the Islamic religion. A'udzu billahi minasyaitonir rajim. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa ashabihi ajma'in. Rabbi israh li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Rabbi zidni ilma warzuqni fahma waj'alni minas salihin. Ya Allah ya Rabbana, we praise you and are grateful for your grace and favor. For you have gathered us in this honorable place for the opening of the fourth international conference of Health Polytechnic of Medan 2025. We ask for your blessing and mercy to be poured upon this event. O Allah, the most merciful, grant us success in this international conference. Make this gathering a source of beneficial knowledge, profound understanding, and innovative ideas that can contribute significantly to the advance of health and well-being for all mankind, both locally and globally. O Allah, the all-knowing, inspire the speakers, researchers, and participants with wisdom, clarity, and the ability to convey valuable insight. Open our hearts and mind to receive and internalize the knowledge shared, so that we leave this place as better individual equipped to serve our communities. O Allah, the givers of ease, make every step, every discussion, and every session easy, smooth, and full of blessing. Protect this conference from all disruption, misunderstandings, and shortcomings. Unite our hearts upon goodness and share goals. O Allah, the most forgiving, forgive our sins, the sins of our parents, our teachers, and all those who have contributed to our education and success. Accept our deeds and grant us goodness in this world, goodness in the hereafter, and protect us from the punishment of the fire. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Arsyad, for the prayer. Ladies and gentlemen, we move to welcome speech and opening remarks, the fourth international seminar of Medan Health Polytechnic of Ministry of Health that will be delivered by the Executive Officer of Director of Medan Health Polytechnic of Ministry of Health. To Ibu Tengku Sriwayuni SSIT MCAP, we welcome you with respect.
Bismillahirrahmanirrahim. For the fourth international conference of the Medan Health Polytechnic of the Ministry of Health, Development of Maternal and Child Health Service in Primary Care Integration. First distinguished Deputy Minister of Health of the Republic Indonesia, Estimate General Director of Health Workforce. Third, all respected keynote speaker, Professor Dr. Adang Bahtiar, MPH, DAC from Indonesia, Dr. Nola Aholnes from Florida, Ethel Maifaigao Onas, RND PhD from Philippines, Dr. Haslina Mukhtar Ajamer from Malaysia, Dr. Fitri Widyaningsi, MS PhD from Indonesia, Midori Anami Akimoto, PhD, WHO, WPRO, Masrah SPD, MCAS from Indonesia, and Dr. Haripin Togap Sinaga, MSMCIN from Indonesia. Fourth, and all the esteemed speakers and reviewers joining us today. Fifth, dedicated lectors, researchers, clinical practitioners, and students, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all of you. It is profound honor and pleasure to welcome you to the fourth International Conference of the Medan Health Polytechnic in 2025. This conference mark our fourth year, bringing together bright minds from across the globe to collaborate on crucial public health issues. Although we meet virtually, the spirit collaboration, inquiry, and innovation is stronger than ever. On behalf of Medan Health Polytechnic of Ministry of Health, I extend our sincerest gratitude to every participant. Whether you are presenting your valuable research or engaging in the discussion, your presence affirms the shared global commitment to advancing health services. This year, we focus our attention on a theme of paramount importance: development of maternal and child health service in primary care integration. This theme is not just timely, it is a direct response to Indonesia health system transformation, especially the emphasis on primary care integration. The development of maternal and child health service seamlessly integrated through the life cycle approach in primary care setting like Medan Health, Polytechnic, and Posyandu is fundamental to reducing maternal and child mortality and addressing critical issues like stunting. We are committed to exploring how technology, research, and police can fortify this primary care pillar. Our goal, the simple, to ensure every mother and child receives accessible, promotive, and preventive care from their community health service. Over the next 2 days, we will hear from 8 Woods class expert and each with numerous oral presentation spanning midwifery, nursing, dental hygiene, laboratory technology, pharmacy, nutrition, and environmental health. I hope that his platform will serve as a catalyst. I encourage every researcher and practitioner have to share insight, challenge existing paradigm, and forge new international partnership. Let the research presented here not just be published, but translate into tangible, scalable innovation that generally improve public health outcome. Finally, I wish to acknowledge the tireless effort of the organizing committee and our dedicated staff who made this event possible. With the blessing of Allah Subhanahu wa Ta'ala and the collective commitment to healthier future, I now officially declare the fourth International Conference of the Medan Health Polytechnic of Ministry of Health 2025 officially open. Thank you, and may we all have a fruitful and inspiring conference. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much to Bu Puan for the speech. Ladies and gentlemen, the opening ceremony of the fourth international seminar of Medan Health Polytechnic of the Ministry of Health 2025 will be dismissed soon, and we will go to the next event by material delivery. And before we start material delivery for all our distinguished speakers, we will have a photo session before. And please, the IT committees to take the photograph of our opening ceremony today. And I invite all the participants to open your camera and we will take the photograph. We take the first slide. 3, 2, 1. Okay, next we move to the second slide. Then third slide. Fourth slide. And this is the last slide, fifth slide. Thank you, ladies and gentlemen, for the cooperations. So now we will move to the next session. We will have material delivery from our distinguished speakers, and these sessions will be guided by our moderator, beautiful moderator, Ibu Rasmina Anggi Sidabutar SST MKM. And without further ado, we invite Bu Rasmina Anggi to the screen now. Thank you, ladies and gentlemen.
Thank you very much. Thank you very much, Mrs. Hannah, for introducing me. Am I audible? Okay.
Yes, you are.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen, and welcome to session 1 of the fourth International Seminar on Development of Maternal and Child Health Services in Primary Care Integration, organized by Medan Health Polytechnic of Ministry of Health in 2025. First, let me share a pantun. Yeah, I hope you can give me emoticon, yeah, and cakep, of course. Bunga melati harmoni disusun rapi di atas meja. Sesi pertama akan kita mulai. Mari kita belajar dari para ahlinya.
Cakep,
Thank you
great.
very much. The Honorable Esteemed General Director of Health Workers of the Ministry of Health, Ibu Dr. Yuli Varianti, MFIT, Executive Officer of Director Medan Health Polytechnic of Ministry of Health, Ibu Tengku Sriwayuni, SSIT MKEP, all Deputy Directors of Medan Health Polytechnic of Ministry of Health, all distinguished speakers, and all participants in this international seminar. I am Anggi, and I'll be your moderator for today's session. We appreciated you presence joining us virtually, and we kindly ask everyone to keep their microphones mute unless speaking during the discussion session to ensure a smooth and uninterrupted presentation, of course. Today, we are honored to have distinguished speaker who will share their insight and latest research on improving maternal and child health services through integrated primary care. We encourage you to take notes and prepare your question for 30 minutes Q&A session at the end. Okay, this session runs from 10 till 30, and the future our distinguished speaker in this session. First, we have Professor Dr. Adang Bahtiar, MPH, DSG from Indonesia. Second, we have Dr. Nola A. Holness from Florida, USA. And then we have Edelmay Faigo Onas, R&D PhD from the Philippines. And the last, we have Dr. Haslina Mutar Ajamir from Malaysia. Now, let us know, welcome our first speaker, Professor Dr. Adang Bahtiar. Please, Professor.
Yes, thank you very much, Anggi.
Okay, thank you very much.
So, very good morning to all participants and honorary guests and the presenters. Assalamualaikum warahmatullahi wabarakatuh. Anggi, can you hear me?
Yes, I can
Okay then.
hear you clearly, Professor. But before we start, let me read your CV, okay?
Oh, that's nice. Thank you very much. Please do.
Okay, please. Yeah, we've seen the CV of Professor Dr. Adang Bakhtiar, MPH DHC. Yeah. Yes, we see that the education background. Now, Professor graduated from Johns Hopkins School of Hygiene and Public Health USA in 1992. Yeah, and Professor worked from 2008 until now, yes, Professor, in Global Fund for TB, Round 8 for
Yes.
Public Health Principal Recipient, yeah, as Managing Director, yeah, and continue, please. Nah, okay, wow, it's very lots. Okay, continue, please. And okay, now Professor work from 1980 ya, Professor ya. Sudah berapa tahun itu?
Mhm.
Been, sudah 40 tahun ya Profesor ya berkiprah di
45. Yes.
for
Yes. Sure.
45 years ya di bidang ini di kesehatan. Nah, untuk research activities ini Profesor sekarang adalah chairman board in expert in public health service course in Indonesian Public Health Association atau IPHA. Oke, ke bawah silahkan. Next. Nah, also in public services. Ya, ke atas dulu sedikit boleh. Nah, from 2007 till now, he's health development programs for Aceh Reconstruction and Rehabilitation Institution. Yeah, as technical advisor to Deputy Welfare. Okay, continue. Nah, I see there are so many publication. Please continue. Nah, in 2000, yeah, next. Okay, it is about 70. Ya, ada 75 ya Profesor ini untuk publikasinya sekitar ya. Saya sudah menghitung tadi, wah banyak sekali. Luar biasa sekali Profesor sudah
Thank you, Anggi.
ya sudah memberikan publikasi yang sangat bermanfaat untuk kemajuan ilmu di Indonesia tentunya ya. And the latest is at 2018 Profesor ya.
Yes.
Ya, yeah, so many publication of the professor 2019. Okay, continue. We find the latest. Okay, wow. So many. Okay, the latest is at 2022. How to engage patients in achieving patient safety, a qualitative study from healthcare professionals and perspective. Okay, yeah, we've seen the CV of the professor. It's so many. And today, Professor will give us topic about exclusive breastfeeding challenges for informal workers in North Sumatra. Is that correct, Professor?
Yes, Anggi. Thank you.
Okay, now let us now welcome Once again, our first speaker, Professor Dr. Adang Bakhtiar. Professor, the floor is yours. So please, Professor.
Thank you again, Angie. So, very good morning again to all of you. I'm sorry I couldn't put my video because the bad connection, so I will not use my video. Very good morning and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
This is a very good moment for us to present state of the art related to mother and child health. Hundreds, even maybe millions references related to this issue, but only small amount related to exclusive breastfeeding, especially among informal worker at traditional markets. Allow us, Dr. Penny, a lecturer from Delhi, Husada, Delhi, Tua, and I to present our PhD study about it in semi-urban areas in Deli Serdang, North Sumatra, Indonesia. The focus of the study is on the strategies to implement exclusive breastfeeding among informal workers at traditional markets. We will highlight barriers faced by informal workers, including being working hours, lack of facilities, and cultural beliefs. Then we propose policy option for local government different from what they believe supposed to do. This is really very a novelty research. I herewith introduce my colleague, Dr. Penny Medan, to present her study about it. And the presentation, the PowerPoint is in English, but allow us orally we will use both languages since the most of participants are berbahasa Indonesia. Please, Dr. Penny, to present your PhD study.
Okay, thank you, Prof, for the time. Excuse me, Ms. Anggi. Can I share my presentation by myself?
Okay, please.
Okay, thank you. Okay, thank you, my Honorable Prof. Adang Bahtiar, and all of the speaker and committee and all the participants of this conference international. I'm Dr. Penny Aryani. Today we'll explore various informal market workers for exclusive breastfeeding and the evidence we collect in North Sumatra and practical policy or research solution. This work was done with Prof. Adang Bahtiar and colleagues in Andalas University. By the end, we'll know what prevent exclusive breastfeeding among informal workers here, what works and what policy steps we recommend. Here are the main root causes we identified. First, many traditional markets lack private, hygienic lactation rooms. Mother ends up breastfeeding or pumping in uncomfortable or unsanitary places. Second, irregular and long working hours make scheduled breastfeeding or pumping nearly impossible. And the third, weak coordination across stakeholders from health, trade, market managers prevent practical solutions. And the fourth, social norm discourage breastfeeding in public. And finally, even when national policies exist, enforcement at market level is inconsistent. Whoever has seen or worked in market like this, how many of you think that the single or postnatal visit can change a mother decisions to exclusively breastfeed, which we found on our research that postnatal visit were the strongest predictor with the OR 62.6. And the consequence or the impact are multi-layered. Infants are exposed to early formula or in inappropriate foods, increasing infection and malnutrition risk. So mother's recovery and mental health can worsen. Families face higher health care and formula costs, reducing household resilience and At a population level, low exclusive breastfeeding undermines public health targets. And so higher rates of infant morbidity and mortality. It consists or it become high morbidity and mortality who doesn't breastfeed from their mother. The evidence of ineffective exclusive breastfeeding policies exist but are fragmented. Overlapping or conflicting rules across sector complicate implementation. Budgets for lactation facilities are limited, and national or local policies often don't account for the realities of informal market works, and they are not tailored. So we ask, what practical context-sensitive solution could work? Now, we will see the barriers of implementation breastfeeding policy in the informal sector. The first, economic barriers. Many mothers must return to work within days or in a couple of weeks after delivery because the family needs their income. The immediate return makes scheduled breastfeeding or expressive milk very difficult. Second, social and cultural barriers. Stigma about breastfeeding in public and negative reaction from customers or co-workers discourage mothers from breastfeeding at the workplace. And the third, educational and informational barriers. Misinformation about expressed milk, low awareness or of practical pumping or storage solution, and limited counseling at the time of delivery leave mother unprepared. Fourth, from the infrastructural barriers, markets and informal workplace typically lack private, hygienic lactation corner, self-mix storage option, and place to rest briefly for feeds. And the five, with the policy and legal barriers, existing breastfeeding policies rarely reach the informal sector. There are gaps in who is protected, no enforcement at market level, and little budget for facilities. And the sixth, in the health system barriers, services are clinic-based and often not flexible. Mother prefer postpartum support at home or at work, but outreach is limited. So we propose solution via policy development and research. Innovation for North Sumatra. We propose a policy development research approach that adapt WHO recommendation to market context. In the contextual adaptation, cross-sector collaboration with health, trade market manager, mobile postnatal service to reach mother at work, and scalable model, and the penny model can be replicated across the district. So imagine small chains, mobile visit, lactation corners, multiplying across market. Which of these seem easiest to implement in our area? And we will choose with the specific area. And the conceptual framework, our intervention package includes firstly, mobile promotive health teams visiting market. Second, midwife training on practical exclusive breastfeeding counseling for market mothers. The third, awareness campaign to reduce stigma. And the fourth, peer support group among market mother. And the fifth, establishing private hygienic lactation rooms in market. And for the study design and stage, the first, situational analysis and stakeholder mapping, conduct an initial desk review and policy scan to identify key challenge related to exclusive breastfeeding, followed by stakeholder engagement to understand the roles of market manager, health authorities, and informal workers. And the second, quantitative survey, measure factors impacting exclusive breastfeeding outcomes, such as workplace integration of breastfeeding service, access to lactation facilities, and flexible postnatal support, utilizing odds ratio-based analysis for robust funding. And the qualitative inquiry facilitate focus group and interviews with market mother, health worker, and community leaders to reveal the cultural, logistical, and social barriers to exclusive breastfeeding, ensuring the intervention aligns with actual needs. And odds ratio show how strongly something like postnatal visit predict exclusive breastfeeding success. And for the case stage in our research, monitoring and evaluation to integrate postnatal visit data into maternal health records, SKIA registers, conduct quarterly evaluation and refine process based on feedback and emerging challenges to ensure long-term effectiveness. And policy advocacy and scalability promote the formalization of exclusive breastfeeding supportive local regulation and sector-specific budget allocation while engaging policymakers to scale intervention across all markets in North Sumatra. And for research finding, first, quantitative highlight, we know that health promotion media strongly support exclusive breastfeeding with the OR 14.1. And postnatal visit were the strongest predictor with the OR 62.6. That means mothers who receive visits were far more likely to exclusively breastfeed. Availability of hygienic lactation facilities increased exclusive breastfeeding likelihood with OR 6.1. And long or irregular hours were associated with lower exclusive breastfeeding with the OR 4.2. Also, for 80% of mothers prefer postnatal visit at home or at work, and many return to work within 4 days postpartum. And the qualitative data reinforce that peer group helps sustain breastfeeding, that markets are logical integration point for maternal service, and the flexible services are essential given mother schedule. Stigma remains a barrier, and cross-sector cooperation is required for effective intervention. And for the 3-hour result finding in qualitative insight, we will make the implication, the policy implications. From the addressing cultural stigma and the intersector cooperation and with policy integration, we make the policy implication include adopt municipal regulation to institutionalize exclusive breastfeeding support in market, strengthen coordination between health and trade department, introduce labor protection like mandated breastfeeding breaks for informal worker, allocate budget for lactation facilities, and deploy mobile formative term as a service model. Importantly, build this element into regulation and budget for sustainability. So we will check in our local health what would we take to pilot one from this result finding. And the infrastructure investment, first establishment of lactation facilities, mobile postnatal service model, and integration of infrastructure into policy frameworks. And the further research, cost effectiveness studies, we open for collaboration in regional Asia for solution. We recommend that cost effectiveness studies comparing market-based visits versus clinic follow-ups, longitudinal impact evaluation on child health, and tracking maternal economic outcomes. This will help policymakers justify budgets and scale intervention. And we are open to collaboration for regional studies across Asia. This is not just local, and it has broader relevance. And for the impact evaluation, we will child health outcomes monitoring, maternal economic support tracking, and community level benefit assessment. And thank you for listening. I welcome question and collaboration. If you have suggestion on market partners or local leaders we should engage, please share them now. Thank you for the time and I back to moderator.
Thank you, Bu Dr. Penny.
Okay.
We will close the presentation and encourage for everybody to join us for a discussion and further collaboration. Go back to moderator Bu Anggi, please.
Okay, thank you very much, Professor. Okay, we will open Q&A session at the end of the fourth speakers. Yeah, so please take notes, ladies and gentlemen. And thank you very much, Dr. Penny, for your presentation. And now we'll go to the second speaker. Yeah. Uh, okay. Hello, Dr. Nola Holness. Hello, you're so
Hello.
beautiful. Good morning in here in Indonesia is morning. How about in there, Florida?
10:24 p.m.
Oh my
It's
God.
in the night.
I guess you must be sleepy, of course.
Been a long day.
Okay, thank you. Yeah. I will introduction for Dr. Nola Holness. Okay. Improving maternal and child health from a global perspective requires innovative approaching up in primary care integration. And Dr. Nola Holness is from Florida, brings valuable international insight with her research of healthcare and system maternal health strengths. Okay, today's topic is about Jamaican adolescents' mothers' perinatal experience during the COVID-19 pandemic. Is that right?
That is correct.
Okay, thank you very much. Before begin, I will read the CV from Dr. Nola. What should I call you, Dr. Holness or Dr. Nola, please?
Dr. Nola is fine.
Okay, thank you very much. Okay. Um, Nola Holness, PhD, CNM, APRN, AP in BC, CNA, VA, CNM. Okay, that's very long title, you know. That's very long how to say, that's very long journey from your education, I see. Yeah, she serves as chair of the undergraduate nursing department of the Nicole Wertheim College of Nursing and Health Science. She is a triple FIU alumna, having obtained her BSN, MS, and PhD degrees in the Nicole Wertheim College of Nursing and Health Science. She worked at Jackson Memorial Hospital as a certified nurse midwife, providing care mainly to underserved women. Her research interest is to change the reproductive health of adolescents, and Dr. Holness has published on adolescent pregnancy and presents at regional, national, and international conference. She has awarded the Undine SEMS Research grant toward his research on preventing a repeat adolescent pregnancy. Dr. Holness is conducting research with an eminent team of researchers on, reducing vaccine hesitancy of pregnancy African American women. Yeah. Okay, ladies and gentlemen, please warmly welcome our Dr. Nola Holness from Florida. Dr. Nola, the floor is yours.
Thank you so much, Miss Angie, and thank you to all the distinguished members, the committee. Thank you for inviting me again. As I said, it is very dark here. My eyes are closing, but I am happy to be here to be a part of this prestigious conference. I went to Bali 2 years ago and met a number of midwives and nurses at that conference, and we created some real deep friendships. I was very impressed with the work that you do in this part of the world, and to know that you are focusing on maternal health and how we can improve globally mothers' morbidity and mortality and infant outcomes. It really makes me feel great to be a part of this team.
Thank
I
you.
must apologize because my co-worker is here with me, my colleague, but she's not able to get in. I know Miss Desi is trying her best to get her in as well. So I must let you know that although I live in Florida and work at Florida International University, my heart is in Jamaica. I am from Jamaica, which is a developing country as well, that has its own share of medical, surgical, maternal issues as well. So every opportunity I get, I go back to Jamaica and conduct research there and meet with a team there. So if you could move to the other slide. And
Okay.
again, thank you for having me here at the Fourth International Conference, and it's a pleasure to be here. So I want to share with you the work that we have been doing in the Jamaican adolescent mothers' perinatal experiences, especially during COVID-19. We all know that COVID-19 is a very, very serious, dangerous viral infection that affected the whole world, where millions die. And this was primarily with respiratory symptoms, could have been mild, could have been serious with a fever, a cough, flu-like symptoms. But then we had severe respiratory syndromes, and then we had the cytokine response, where you had multi-system and organs that went into failure and created a worldwide death. So we felt that this was very important in Jamaica to see how our adolescent mothers were coping with the COVID pandemic while they were pregnant and had to go to have their babies. We felt it was significant to see how they were cared for and how they felt that their experience was. And I hope I can hear from the Indonesia side as well how your adolescents cope during the COVID pandemic, or even how they are coping now. I really enjoyed Miss Professor Ariana, was it? Ariana's just now? Her presentation on breastfeeding, because that is one of the key factors you want for pregnant women to make sure they can breastfeed. And I'm really impressed that you have identified that postnatal visits affect how they breastfeed. So I think it's important for us to look now at how our Jamaican adolescents, how they cope with their experiences of pregnancy and delivery during the time of the COVID pandemic. What we're going to look at is how we conducted this research, what were some of the ethical considerations, the populations and the setting, the sample size, the sampling procedure, how we went about to collect the information, what were some of our procedures, and we'll quickly look at our findings, our discussions, our conclusions, and our implications. Bear in mind that I cannot stay until after everyone has presented because I have to go to work early in the morning. So I may leave after we're finished, but please send your questions and I will email the answers back to the committee so at least we can still have some dialogue and have some clarity on what your questions are. We can move to the next slide, please. Yes. So here we talk about the fact that adolescent pregnancy, and I'm curious to hear, so hopefully you will send me some information as well as to how adolescent pregnancy is viewed in Medan, in the Philippines, in other countries, in the Indonesian region. Because for us in Jamaica, this is seen as a social issue that affects not just the adolescent, but her families and her communities for generations. A young lady, 14 to 19, having a baby in Jamaica is seen as a problem. We know that annually about 750,000 adolescents become pregnant, and this leads to social, economic, and health problems. In low and middle income countries with limited resources, girls who are less than 18 account for 95% of all births. So we know that adolescent pregnancy is a global problem. The rates of pregnancy in Jamaica is about 51 per 1,000 births. I don't know what your rate is. I'll be interested to hear as well. The fact that the COVID-19 pandemic happened, this increased the rate of adolescent pregnancy, and that led to even more complex problems that surrounded adolescent pregnancy in Jamaica. Some of the barriers that the adolescent moms will face will be family planning for her to get access, for her to be able to develop any kind of self-determination, and of course, her education is severely affected as well. She may not have health information or health services because there are inadequate resources, unsupported health care in our environment. Stigma is a big one because, like I said, it's not a very good thing for young ladies to get pregnant in Jamaica. That is seen as a very wrong decision that she made and that she became pregnant. There may be a lot of disrespect for her and there's poor knowledge of the healthcare worker as to how to care for the adolescent during the perinatal period. So the perinatal services that adolescent moms use is not well utilized because of the stigma and the negative stereotype. They don't feel like they're cared for. So resilience, tolerance, and a supportive healthcare environment will help her to seek those services and be able to have a better outcome for herself and for her child. So this study looked at how these women, these adolescent moms, how they coped during the healthcare, in the healthcare environment, and their perception of the care that they received during the pandemic. So what do we want to look at? We want to determine what are some of the factors that will influence the adolescent mother's experience. We want to know her perception of the healthcare system during the pandemic. We want to find out if she thought there was any benefit to the prenatal care that she received. And we want to find out if the COVID-19 protocols have had any influence on her experience. So here we did a literature review. We went in to see what were some of the issues that surrounded adolescent pregnancy. We know that there are protective rights of the adolescent mother. She has a right to freedom from stigma and any kind of discrimination. The highest attainable standard of physical and mental health should be afforded to her. Respect and understanding the social, political, and historical context in which they live and raise their children is very important. We wanted to see what are some of the standards of care for adolescent women. Comprehensive perinatal care is essential for all adolescent women. So every young girl deserves to be well cared for while she is pregnant. And this care involves physical, developmental, psychological needs of the child and the adolescent parent during the entire perinatal time of pregnancy, labor, delivery, and the postpartum period as well. When we deviate from some of these sexual and reproductive health outcomes, when we deviate from the standards, then the parents are not given the priority of the care they need, and it may be due to a knowledge deficit from the healthcare worker about adolescent care. So adolescent moms now and their perception, they may have a negative perception, and this will hinder how much care they will receive. I think Ariana talked about the care that the informal workers get as well. So it's important that these moms know where the services are and that they're able to access the service. And like we said, respectful maternal care can lead them to have a positive perception of the healthcare environment. So what are some of the past experiences of these adolescent mothers? We talk about stigma. We talk about the wrong attitudes of healthcare and social care professionals, that these may have a negative effect on the health of the adolescent mom. If there's stigma and unsupported care, then they're not going to use the healthcare services well. Again, any kind of stigma and discrimination creates a barrier to family planning. And what happens? They get pregnant again because they do not have access to the different types of family planning services that are available. Pregnancy and childbirth, these complications can cause a lot of death among adolescent women worldwide. So it's so important that we do our best to find out how we can give them the very best care possible. The outcomes of these moms, when they are not given the priority, can again be because of parents not being able to, not the healthcare workers not giving them the proper services that they need. And I must make a correction here at this point. I did ask Miss Desi to make sure that the slides have FIU emblem on them. So I don't think we're using the correct slides. But bear in mind that what is going to be left on this presentation, the slides will look a little bit different because it must have the FIU logo on it for us to be able to use FIU information on the certificate. So just want to make that very clear. Thank you. So what are some of the experiences then? Like we said, the pregnant woman during the COVID pandemic may have a negative effect, may have a negative perception and not utilize the care. She may feel anxious, fearful, scared, isolated, and lonely. And midwives and other healthcare providers need to have intensified efforts to support the adolescent mothers because of all the challenges associated with COVID-19, like I just mentioned. If a pregnant woman gets COVID in the past or even now, that can lead to severe medical respiratory problem for her. Mom may end up in the ICU for intensive care. And the babies, if they contract COVID, then they can end up in the NICU very, very ill as well. May even need ECMO. I hope that you are familiar with that term. And may be so severe that the babies may absolutely die as well if they are not properly cared for urgently. And the same from mom, as we have seen. Next slide, please. So what's our conceptual framework? We looked at the behavioral model. We look at some of the predisposing problems. What are some of the enabling conditions that can help a mom in a vulnerable situation? What are some of the need that she may have, the health behaviors, and what are some of the outcomes that we're looking for? Remember, we mentioned social stigma is a significant problem. This can come from family members and neighbors. This can come from the healthcare facility, and as well as mom, the teenager may have such a poor perception of herself, the fact that she's pregnant and all the stigma attached to it, that she may not seek care, and also that her condition may worsen because of the stigma attached to her condition at this time. Next slide, please. What method did we use for our research? We looked at a qualitative design. We looked at moms who had delivered their babies during the COVID-19, and they were in a special center called the Women's Center in Jamaica. That's where pregnant women go for school, and they have a social interaction because everybody there is pregnant. So they have an opportunity to support each other in that setting. We had 8 pregnant women who were the sample for the study. This was purposive sampling where we selected the 8 participants from 4 regions across Jamaica. So 4 different sections of Jamaica, we selected the participants and then conducted the interviews with them. We had 28 items on a structured interview that we administered to these 8 pregnant women. We collected the data between July and December of 2022. We did the interviews on the telephone a week after they had delivered. We recorded and stored the information, and then we analyzed the data with coding, and were able to extract themes and categories from the data. Ethical considerations did come from the university that we conducted the study, as well as from FIU, as well as from the Women's Center, where we got the subjects to participate in the research. Next slide. So what are some of the findings? We identified that these adolescents were aged 13 to 17. They were from all grade level in the secondary school, and they all took part in the public healthcare system across the 4 regions of Jamaica. Next slide. Themes that came out that we were thinking of that could be developed. We wanted to look at the support system. We wanted to look at service delivery, health education, and how they felt about the COVID protocols. Next slide. So we wanted to look at some of the factors that could help the moms. So here I am going to tell you of some of the findings from the adolescents and what they thought about the the objective question that we were looking at. What were some of the factors then that looked at their perinatal experiences? Their mother, baby father, baby's father and mother, stepmother, stepfather, siblings, all these individuals influence the decision of that adolescent mother to get prenatal and maternal care. So what were some of the comments that they made? When we asked them, who do you live with? Who influenced your healthcare decisions while you're pregnant or after you've had the baby? One of them said, my baby father, oh miss, says she, her mother, bring me the first time, and after that she kind of let me go because I understand. Then the baby father and the baby father's mother help me. Like sometimes I forget to carry something, but they will pack my bag overnight. So these are the people the adolescent mother said gave her all the support she needed to be able to go to the clinic and get the prenatal services that she needed. So support is vital if the adolescent mother is to engage with the healthcare system. And from this objective, we saw that our clients did have support. Next slide. We wanted to see what is her perception of the healthcare system during the COVID pandemic. So the question was, how would you describe the care you received during the antenatal visit, labor and delivery, and after delivery? And they generally responded, excellent, great, good, never treated me bad. So they felt it was well done. Let me just stop a little again and ask, did my colleague make it in to the meeting, Miss Desi? She is Miss Verona Ferguson Henry, and she was supposed to be joining me to participate as well in the presentation. So if she's here, I would love for her to participate as well. Can we verify if Professor Verona Henry Ferguson was able to make it in? I know she was trying to get in and she couldn't. All right, please indicate to me if she's here. So the participants felt like their responses were great. The care they received made them feel like they were a newborn baby, they said. So overall, they were satisfied with the care. They felt like the support was good, and they felt like it was respectful maternity care, and that led to a positive perception of the healthcare system, and this can help to reduce stigma and any discrimination. Next slide. The third objective we wanted to look at was to examine the adolescent mother's perceived benefits. What benefits did she think she got from her prenatal care during the COVID-19 pandemic? And the question we asked was, how would you compare your health practices before you receive the information from the healthcare providers versus after you receive the information during your pregnancy? One participant said, when I learn the do's and don'ts, I keep myself healthy and I keep the baby healthy too. So they felt empowered and more resilient in maintaining a healthy pregnancy and post-delivery self-care after they had received that instruction and information from the healthcare system. Next slide. Our fourth objective was to determine if the COVID-19 protocols influence the adolescent experience. So the question we asked was, in light of COVID-19 pandemic, how do you feel about going to the health center or the hospital for care? One of them said, I didn't like it. I had to wear the mask, and the mask made me feel uncomfortable. And the sanitizer had an awful smell. It was frustrating and it was stressing. Another one said, I didn't feel anyway because I just followed the protocols. So the participants demonstrated a wide range of emotions related to the COVID-19 protocols. And when we look at the literature, we find that yes, some people will have negative feelings, and we were able to identify, though, some positive responses as well. Next slide. So bear in mind that every study will have some limitations, yes? So this study, we used a structured interview for the data collection, so that could have a potential for some bias. Nevertheless, we were careful to allow the participants to share any comment that they may have had. Next slide. So what are our conclusions? What are our implications for practice? We think that there's a community of support which results in a positive experience for these adolescent mothers. Their mothers were the most influential support for them. They perceived the healthcare environment as a caring one. They felt supported by members of the healthcare team, which then facilitated their willingness to access the healthcare services. They demonstrated a wide range of emotions related to COVID-19 protocols. Most were comfortable and adhered to the protocols when accessing care. Nevertheless, we feel like there is continued promotion of enabling factors that will help to provide effective perinatal care for pregnant adolescents in Jamaica. And the rest of the slides will be the references. And thank you for your time. Like I said, I really have to go. It's almost 11 p.m. here. And I thank you again for allowing me to present. And I will hear from you all if you have questions. And I will do my best to send back those answers as well. I don't know if you want to break protocol and ask me any questions before I go, Madam Moderator, Miss Hannah? Or you want to just email me the questions later?
Okay, thank you very much, Dr. Nola. I am Anggi. You can call me Anggi. Hello, can you hear
Hi,
my voice?
Angie.
Okay, hello. Yeah, okay, thank you very much for your presentation. And yeah, for the Q&A session, we'll open in the last time, yeah? Okay, okay, yeah. Especially for Dr. Nola, yeah, we'll open Q&A at this time because Dr. Nola has another things to do, of course. For the participant who has a question for Dr. Nola, please raise your hand, or you can type in chat. I'll read it for you. Please, for all the participants, if you have question.
I hope the presentation was clear to everyone.
Yeah, I think so. Your presentation is very clear. That's about the perinatal experience during COVID-19, of course. Yeah. Once again, I'll give your oh, okay. Okay. Uh, there is one question from Mrs. Dina Mariana for Dr. Nola. She asked about the the culture of pregnancy woman in Jamaica. Is there any difference with the Indonesia?
Well, you would have to tell me.
Okay.
Because
Yeah, that's correct, I guess. Yeah. Like an example, maybe I'll give you one example. Like in Indonesia, pregnancy woman may not be able to stand in front of the door like that maybe. And in Indonesia, that pregnancy woman may not use hair clip in Javanese. They apa? they forbidden to use hair clip because they believe in they believe in Java thinks that if we use hair clip, the baby will get apa namanya?
A mark or something?
Will get by umbilical. Iya. Stuck by umbilical cord. That's
Oh, that's
one of
serious?
yeah. That's
Okay.
one of the culture in Javanese. But
Yes.
right now there are no just only small people who believes in that. Maybe
Mm.
question from Dina Mariana is how about in Jamaica? What is the culture about
Yes, yes. Okay.
there anything
It what,
special in that?
yes, one thing I can remember for us in Jamaica, if you are hungry or if you desire something and you put your hands on your body, wherever you touch, the baby will have a mark there. So say you desire a slice of cake or something and you don't have it, but
Pink.
you scratch your tummy or you scratch your hand, we believe the baby will come with a mark.
Oh,
Again, only a small amount of people believe that now. Uh,
okay,
we
okay.
believe that, well, you will see some pregnant women eating chalk or eating clay,
Yes.
and that is called pica. And I don't think it's just for Jamaica, but it's like a craving, and women will eat that. So we have to educate them not to eat it because it occupies and fills the stomach, and then you won't be able to eat the food that you need to eat.
Oh
But
yeah.
this is a culture that, yeah, this happens in Jamaica.
Yeah, but that's not happening in Indonesia. There are no pregnant women eat that clay, I guess. Yeah.
Interesting. Okay, because I know it happens in other countries as well. So
Oh,
it's interesting to hear that it doesn't happen in Indonesia. I
inshallah.
see two hands are up.
Oh, you've seen a lot of people craving that things when pregnancy.
Yes, yes.
Okay, okay. There are another question from Mrs. Hannah. You may raise your hand.
Okay, I have already
Okay,
raised my hand.
okay, please.
Okay, thank you for the chance given to me, Bu Anggi. Hello, Miss Nola.
Hello.
I'm Hannah from Midwifery Department in Medan. Major in midwifery department in this Medan Health Polytechnic of Ministry of Health. Miss Nola, I will ask you a questions. What is the main barriers experienced by pregnant women in Jamaica when assessing quality midwifery services? Thank you.
Thank you for your question. As a midwife who practices in Jamaica, I would like to say that the quality care we give is accessible to all,
Okay.
and women do utilize the services.
Yep.
We have not just a hospital, but we have health centers that
Mm,
provide prenatal care.
mm.
So it's not that women all have to go to a large hospitals, but within their community, our healthcare services with nurse midwives, with nurses, they can go there for the prenatal care, then deliver in the hospitals and come back to the healthcare system in their community for their postnatal care. One of the biggest barriers I would say is maybe
No.
education in some regard, again, for moms and their families to be able to access all the care, get
Yeah.
the information. But I know we do a really good job
Mm,
of educating and allowing access to care. So really, I would say there are very, very few barriers. The problem is, Miss Hannah, like I explained just now, it's the adolescent moms
yeah.
who are scared to tell their mom or their dad that they are pregnant.
Wow.
So they may go a long time with the pregnancy and try to conceal it, to hide it, so nobody knows. And then they miss out on all those important screenings that need to happen early in the pregnancy. So that may be a barrier. That stigma that we have to try and break. However, I was just on a call recently with midwives from Jamaica, and they are doing a fantastic job of bringing in those adolescents and giving them the care they need. And they are reducing the adolescent pregnancy rates really well in Jamaica.
Yeah. Same condition with some rural area in Indonesia, I think, Miss Nola. Thank you for the answer.
Good, good. I'm glad we can see some of those similarities.
Yeah, thank you, Miss Nola.
Okay.
Was there another hand?
Yeah,
Yeah.
thank you very much for your question, Mrs. And the next, I see that Mrs. Amira raised her hand. Okay, Mrs. Amira, please. Okay. I can't hear you.
Okay, thank you, Miss Anggi. Can you hear me, Miss Anggi?
Oh, okay, you're very clear, Mrs. Amira, please.
Okay, thank you for the chance given to me. Hello, Dr. Nola.
Hello, Miss Amira.
I'm Amira from the Sing Department of Medan Health Polytechnic. It's nice to see you again in this seminar, Miss Nola. Dr. Nola, I mean. Okay, I wanna ask you a question. In your research, there were adolescents involved as participants, right, Dr. Nola?
Yes.
So I just want to know whether they then got married after becoming pregnant or continued raising their babies without being tied to marriage. That's it.
All right. In Jamaica, we have more often than not a matriarchal type of family. It's the mother who really raises those children and is head of the family. So while we do have a large proportion of our population that are married, you still have many that are not. And the fact that a young woman gets pregnant does not mean she's going to get married. Very unlikely. So, because most of these moms grow up and don't see a father in the house, they carry that same kind of a culture. So, getting married is not a priority for a young woman who gets pregnant in Jamaica. Sad to say, but that is the reality. Yes. So again, we try to incorporate the father of the baby. We try to make sure he feels like he's a part of this triad. And it's not just mom and the baby, but he should also be coming to clinic with her, being there when she had the baby, being there the postpartum period. But it doesn't happen a lot. How is it in Indonesia? If a teenager gets pregnant, does she get married?
Yes, Dr. Nola. In our culture, it's the adolescent get pregnant. It's will get a bad stigma if they are not being tied to marriage.
Mm-hmm.
And actually, maybe after the adolescent delivered, and they will give their babies to other families to be raising. Like that.
Oh, for an adoption.
Yes.
Okay. Jamaican adolescents will keep their baby because more often than not, they are going back home where their mother is there as well. So you now have 3 generations of women caring for that baby. The grandmother, the mother, the teenager who was pregnant, and the newborn baby will be in that same household caring for the baby.
Okay, thank you for your answer, Dr. Nola.
Thank you for the insight. Thank you.
Thank you, Miss Anggi.
Okay, thank you very much, Mrs. Amira, for your question and the explanation from Dr. Nola. Okay, once again, participant, I'll give you time. Please raise your hand if there's something you want to ask to Dr. Nola. We'll just open another question. Okay, from Mr. Johnson. Please, Mr. Johnson.
Okay, thank you, Miss Anggi. Good morning, Ma'am Nola. In Medan,
Good night.
Oh, good night. Good night, Ma'am Nola. I want to ask you a question. Excuse me if I'm wrong. You said that your participant is a woman at age 13 to 17 years old, isn't it?
Correct.
Yeah. And only 8%.
Correct.
Yeah. I want to ask, so you follow this woman until they married, until they have a baby or uh, give the breastfeeding? Is it?
For the study,
Yeah.
we saw them 1 week after they have delivered.
Mhm.
We wanted to have them give us an idea as to how the pregnancy was, how their labor and delivery experience was, and now that they've had the baby, tell us how everything went.
Okay. So your finding is about family supporting, about access to health services, about COVID-19 protocol. So you ask them about it, about that.
Correct. Yes, we wanted to find out how they felt that the support they got was how well it was. We wanted to find out why they were in the hospital, why they were there in the school, the women's center. Did they keep the COVID protocols that they were supposed to keep, and how they felt about it? So that's where some of them said it was very frustrating because they didn't like the mask, they didn't like the hand sanitizer, where others said, I did what you told me to do. But overall, what we were happy to see was that even though there is a stigma attached to adolescent pregnancy in Jamaica, while these young ladies were in the hospital, while they were in the health center, they felt like they were supported. They did not feel that stigma. And we were very, very happy to hear that.
So I want to know, how long did you do this study?
We mentioned it from July to December.
Oh, okay.
That's when we interviewed them to be able to get the data.
Okay. And the last, I said that only 8 participants. Is that?
Yes, because that's normal. That's normal for a qualitative study.
Oh,
You can
I
get
think.
rich data.
Yeah.
Because remember, you want to keep going until you get data saturation. So we're able to ask these questions, get information from them, and we could get themes and categories that emerged and be able to see how these moms felt about the care that they were receiving.
Okay. So not the reason of the difficulty of to take the respondent or participant in Jamaica.
I'm sorry,
Yeah.
What is the question?
Only 8 participant is not the reason of the difficulty of to take the participant in Jamaica.
Correct. No. We felt like there are I didn't mention this, but there are research protocols, and sure enough, 8 participants for a qualitative study of this kind was adequate, and that's sufficient to get the data that we needed.
Okay, thank you, Ma'am Nola.
You are so welcome. So go now and do your qualitative study with 8 participants.
Okay, thank you. Thank you, Miss Anggi.
Okay, thank you very much. Mr. Johnson, please do your research with 8.
With 8 participants now.
Okay. Okay, thank you very much, ladies and gentlemen, and especially for Dr. Nola Holness. Thank you very much for the valuable insight. I hope we can looking forward to our next meeting, of course, yeah, and have a restful break. Good night in there in Florida. Good night, and hope can see you in another time. Okay,
Thank you guys so much for inviting me. As always, I do enjoy being in this company.
Okay.
Thank you, and have a good night yourselves.
Okay, we have a good morning here.
Yes. Okay, good.
Okay, ladies and gentlemen, we still have two speakers, and now we will go to the Dr. Ethel Mai Faigo Onas, R&D PhD from Philippines. Hello, Doctor.
Hi, good morning. Thank you for inviting me again.
Good morning. How I call you, Dr. Faigo or Dr. Ethel May?
You just call me Ethel.
Oh,
Ethel.
okay, okay, Mrs. Ethel. Yeah, Miss
Okay.
Ethel. Today's topic is about development of maternal and child health nutrition services in primary care integration, global and Philippines perspective, of course. We'll read the CV. Mrs. Ethel birth in Romblon, Philippines at 20 March 1844. Yeah, yeah, 1984. I'm sorry. Yeah. And she is registered nutritionist dietitian from July 2006. And she's graduated Doctor of Philosophy in Human Nutrition at the University of the Philippines in Los Banos in 2022. And she's worked as the faculty member of the Centro Escolar University from November 2006 to present. And next, please. Okay, she received award Teacher of the Year in 2024. Wow, how amazing! From Centro Escolar University in September
Nice.
2024. And she has many certification training. Okay. And the latest is about is test the NC2 food and beverage service. Okay, next. Okay, now she's been lecture for many event, yeah. And the latest is about a keynote speaker in gut brain axis, the role of gut microbiota in brain health and stroke in Polytechnic Kemenkes Tanjung Karang at September 2025. Okay, please. Okay, so many event. Okay, please. Okay, now. Okay. Mrs. Ethel research. The latest is the oral presentation about in changing the fiber content of dumpling meat, filling using Saba banana. Yeah, Saba banana. Is this banana or banan?
Yes,
Banana.
it's typographical. It's banana.
Okay, banana
Sorry.
peel as a meat extender at the sixth International Conference on Food, Nutrition, Health, and Lifestyle 2004 at the International Institute of Knowledge Management Seoul in South Korea. Wow, that's very amazing. Okay, please move. Okay, I see there are so many presentation. Okay. She also membership organization. The latest is as advisor in SNHM Student Council in 2023 till 2024 and 2024 and till 2025. Now, she also published a culinary arts book at Unlimited Books Library Service and Publishing. Yeah. And the main author is Dr. Ruchi Reyes. I think that's all for the CV. Yeah, ladies and gentlemen, the first speaker speak about the breastfeeding, and the second speak about perinatal experience during COVID-19, and the third will speak about nutrition. Yeah. Okay. Did you know that
All
nutrition
right.
strategies play a vital
Yes.
role in maternal and child health success? Dr. Ethel Maifago Onas is a respected nutritionist and researchers from the Philippines, and specializing in integrating nutrition into primary care models. Okay, please warmly welcome uh, Mrs. Ethel Mai Fago Onas, R&D PhD. The Mrs. Ethel, the floor is yours.
Okay, so thank you, Ma'am Angie, for the kind introduction. So basically, I am a teacher in the university. So I am a registered nutritionist dietitian. So most of my, as you see in my curriculum vitae, most of my researches, they are all based from obesity and its relation to weight management. And most of my trainings are more of the side of nutrition, which is more of the clinical side and food service. So before I start my presentation, do we have here nutrition students or nutrition professionals attendees?
The audience, do we have nutritional? We don't have professional, I guess. But we have
No
nutritious.
more.
Yeah.
All right.
Okay.
Okay, so thank you. So basically, my presentation is about integration of maternal and child nutrition care. Okay, with the collaboration with other department. So I will focus more of the global, just a snippets of the global practice and in the Philippine practice. Okay, so let me present first. Can you see my slide?
Yes.
Okay. So the title of my presentation or my topic is about development of maternal and child health nutrition services in primary care integration. This is for global and Philippines perspective. So to start with, this is the overview of my presentation. I'm going to start with the overview of the MCHN, followed by the delivery channels and international linkages in the Philippines. I'm going to discuss also the concept of integration in primary care, current strategies models in relation to nutrition, policy frameworks and support system, and the impact or outcomes of this integration or primary care integration. And of course, I listed some challenges and gaps in relation to the MCHN integration. And of course, last one will be the future direction in relation to nutrition with regards to maternal and child health and nutrition. Okay, so let me start with the overview of the maternal and child health nutrition. So the first one here, so let me discuss first that in relation to nutrition, our focus is all about the importance of essential nutrients and feeding practices, focusing on the pregnant women, also lactating women, and of course, children, okay, wherein they are directly cared by the mothers. So the focus will be on the preconception, pregnancy, and lactation, and children who are considered age at birth to 5 years. Okay, so what is the importance of MCH and nutrition? So we all know that these are considered the foundation of life, especially the first 1,000 days. It is also considered the most critical period of the human development, and with that, the effect will be a lifelong physical and cognitive health, no, among the mothers and children. And of course, its importance is to save lives, no, and improve the mental health and cognitive health of the children and adults. And focusing on the nutrition side, it significantly reduces also not only the other health effects, but also the nutrition status and reduces mortality among children. And of course, for the improvement of the brain, which is a critical part or critical period of development. And of course, proper nutrition, integrating it with other services in health can also increase productivity and educational attainment later in life among adults. And it can combat poverty and malnutrition if we are well nourished. Okay. As you can see here, this is the link between maternal nutrition and child health outcomes. And we are all familiar with this, the first 1,000 day or the window from conception to 2 years. And we have to focus on this not only in the nutrition side, but also in other side of health or healthcare. So as you can see here, if we have undernutrition status or iron deficiency anemia, folic acid deficiency among pregnant women. And if we will follow optimal nutrition, then these are the long-term, the direct outcome and the long-term outcome. As you can see, for undernutrition, later in life, these children, if they are undernourished, later in life, they will become obese. So as you can see, they are undernourished, but later in life, there is a possibility that they will become obese. For iron deficiency anemia, this can affect the neurodevelopment and school performance. For folic acid deficiency, it is important before pregnancy that they have enough amount of folic or folate intake. It's because this is we cannot treat once they already develop this congenital disabilities. And of course, optimal nutrition from for the first 1,000 days, because we all know that if we are properly nourished, we are free from any infection or illnesses, and the effect is more of the higher cognitive scores. Okay, so as you can see here, this is the global health context, the status, okay, of in relation to nutrition. As you can see here, this is about 287,000 plus, okay, of maternal mortality. And the target of the SDG is less than 70 per 1,000, 100,000 mortality rate. And then for child health survival, this is the global health context. As you can see here, there are 5 million child death. Okay, and the target is 25, less than 25 per 1,000, under 5 mortality rate. So in relation to nutrition and well-being, in nutrition related to anemia, so it says here 26% of women suffer from anemia, especially those who are considered pregnant, okay, because of the blood volume expansion. So most of them are anemic. Okay, on the other hand, in relation to nutrition, this is also related to the previous topics being discussed by our speaker. So it says here, we only have 44% women practicing exclusive breastfeeding from birth to 6 months. So the World Health Assembly, the target will be is 50% exclusive breastfeeding. And we cannot really achieve 100% of exclusive breastfeeding because there are other concerns of mothers who are not breastfeeding exclusively. Either the mother is sick, taking antibiotics, or the mother will tell us that the milk is not enough. That is why they stop exclusive breastfeeding. All right. And then next one, this is the Philippine context or health nutrition situation. As you can see here, 28.8%, no, we have 28.8% children under 5 who are considered stunted. And this is considered a public health significant problem. And in terms of the child mortality, it says here 22 deaths per 1,000 live births among infants. Okay, on the other hand, for the nutrition, actually now we consider it triple burden of malnutrition. Okay, when we say double burden here, it's a combination in our status in the Philippines. There are a high number of children that are considered undernourished and the children that are also considered overnourished. That is why it says here a double burden of malnutrition. So meaning there is a rising rate of overweight and obesity among mothers and adults in the Philippines. Okay, so next one is the historical evolution of the integration of primary healthcare. As you can see here, this image illustrates the historical evolution of the nutrition programs. So before, the early focus is about a vertical program, meaning they only focus in a single disease intervention. Like for example, if there is a program, for example, they will just focus on sanitation or a vaccination, and this program aimed to reduce infant mortality rate. But nowadays there is a shift of from a single disease intervention to an integration, meaning um, um, the programs or the problems or the health problems in the community will not only focus on a single disease intervention. It should be a holistic approach, meaning it is combined with medical, nutrition, preventive services in order to promote the reduction of infant mortality rate. Okay, so as you can see here, this is about the global commitments. Okay, so this image present a timeline of major global health declaration. So as you can see here, we have here Alma Ata Declaration in 1978. Its key concept is primary health care for all, which emphasizes that health is a fundamental human right. Okay, and this promotes collaboration among healthcare providers, and this one focus on the community participation. It is as mentioned in the previous previous speakers, community participation is really important in achieving our goal, which is health for all. And then this is our sustainable development goals. Before, this is what we call this, a millennium development goal. So this, our core agenda is to reduce the maternal mortality rate and under 5 mortality rate in relation to health. And the other one is in nutrition, to end malnutrition in all forms. When we say malnutrition, we have undernutrition, we have deficiencies in nutrients, and overnutrition. And on the other hand, we have Astana Declaration in 2018, and this declaration reaffirmed the Declaration of Alma Ata in 1978, which is that emphasizes primary health care for all, and still considered as the cornerstone of universal health coverage. Okay, so what about the delivery channels and international linkages in the Philippines? So these are the delivery channels in relation to the integration of primary care or the frontline care. As you can see here, we have a rural health units, and I think Indonesia also have this rural health units. And as mentioned by our previous speakers, they also have rural health units in Jamaica. So this is a municipal level in the Philippines. This is the central hub for primary care, like for example, for pregnant women to go there for antenatal or postnatal care. So this hub is a comprehensive maternal and child care nutrition services. They provide all services related to pregnant women or lactating women or children. On the other hand, we also have barangay health station. It is the smallest unit, no, of the community. And in here, basic community outreach is done at barangay level. They can also conduct services, same with the municipal level. And lastly, the LGU-led programs. All of the programs here in the Philippines are led by the local government units. They are in charge for the financing, planning, and implementing. So every time that they conduct a nutrition services, they are present to support, to give financial support, and to provide also manpower in order to implement the programs. Okay. And then we also have intersectoral linkages aside from the rural health units and barangay health stations. We have here, okay, the Department of Health. We have National Nutrition Council. We have Department of Social, Welfare, and Development, and we have Department of Education. All of this are recognized as a national level departments, and they are in charge with different services in relation to nutrition, and can also be used for the implementation of programs related to healthcare. So like for example, for the Department of Health, they deliver clinical services. They are also in charge in distributing to rural health units or barangay levels the micronutrients that is needed. They also conduct maternal nutrition counseling, and they are in charge for the implementation of first 1,000 days. And we also have National Nutrition Council. It is the highest policy-making bodies of the nutrition here in the Philippines. They are in charge in planning the interventions related to nutrition, whether the intervention is a specific intervention or nutrition-sensitive intervention. Of course, we have Department of Social Welfare and Development. They are not directly in charge in nutrition, but they are in charge in helping improve the nutritional status of the community, especially the families. Okay, they are in charge of providing budget. Okay, for families with low income, and we all know that undernutrition is also due to inadequate amount of money to buy food. Okay, they are also in charge in monitoring the health of the families and growth monitoring of the preschoolers. Okay, on the other hand, this is the education. This is for public schools, or this is more of the public schools, high schools, and elementary level. They are in charge in feeding children. The Department of Education, they have a budget on that. Here in the Philippines, about 30 pesos. I don't know if how much is that in Indonesia. About $0.30, okay, given as budget per students for the feeding program. And they are also in charge of the growth monitoring of the pupils or the students. And the next one, okay, so what about the core benefits of this integration among the core benefits of the integration of these services? So it says here, better resource use, meaning it maximizes efficiency by delivering not only nutrition program, but also other health services at one time. Like for example, they can conduct vaccination, deworming, and at the same time, growth monitoring. After the growth monitoring, they can provide food for the children. Okay, it also ensures a seamless transition of care from prenatal stages through early childhood development, and also improve health outcomes if we will integrate this program. So when we say improve health outcomes, by addressing all the needs of these children and mothers, it will improve. These are all interconnected. Those programs provided are interconnected, meaning this can improve the health of mothers, not only mothers, but also the children. Okay, so another one, this is already done. Okay. Okay. What about the concept of integration in primary care? So this is already discussed by the previous speakers. I'm sorry. Yeah. Okay. So when we say integration, not only nutrition is being provided, but also other services. And according to the WHO, they conducted an integrated management of childhood illness, not only focusing on the nutrition side, but also the other health services. It is a comprehensive care for sick children under 5 and continuity of service among pregnant mothers. Okay, so this is the integration platforms here in the Philippines. As you can see, this platform shows how health and nutrition services are organized and delivered at the local level. So these are the rural health units, barangay health stations, and all of the interventions are organized by the local government units. So they are considered the core manpower or the frontliners for the delivery of service. And as you can see here, the other one is the intersectoral collaboration of the different national levels departments working together to deliver health services and not only health services, but also implementing intervention, providing fund for those who cannot buy enough amount of foods, and focusing on the health of the students. So what are the current strategies and models in relation to primary health care? Okay, so this is just an example of a successful maternal child health nutrition integration. So in Bangladesh, we have here scaling up nutrition. So they allow the volunteers to reach the community, focusing on promoting infant and young child feeding practices. They also distribute micronutrient supplements, and this practices is considered a decentralized approach, meaning they allow volunteers or community volunteers to deliver programs directly to the community. In Nepal, they have this integrated management of neonatal and childhood illness, meaning the breastfeeding promotion, especially exclusive breastfeeding from birth to 6 months. They also monitor the growth of the children, and they also have therapeutic feeding among severely malnourished children. And these are delivered by volunteers, female volunteers in the community. And then in the other one, this is in, let me check. Okay, this is in Peru. Okay, they have provide cash transfer, conditional cash transfer program. This is also applied here in the Philippines. Wherein if you are considered pregnant, they will give you an allowance, but that is not that very high amount. Just a small amount that can help in the purchase of small amount of food as an addition for the health of the pregnant mothers. Okay, and they also provide incentives in Peru. Okay, so next one, this is for okay, in US, they have a federal assistance program. They also provide education. I think nutrition education is done in all countries. But here they provide federal assistance, and the focus is more of the pregnant women and children. In Indonesia, this is based from Posyandu Integrated Health Post. Is this correct? Posyandu Integrated Health Post. So this is a community level platform. They reach the community. They train the volunteers in order to mobilize the program, and they conduct immunization monthly. Or they also have here vitamin A supplementation, a micronutrient supplementation. They also conduct nutrition counseling. And in Vietnam, they have this health station. I think this is the rural health station wherein they provide a comprehensive approach in delivering services among maternal and in children. And then they provide counseling for infant and young child feeding practices. And their aim is to reduce child mortality. Okay. On the other hand, we also have integrated antenatal and nutrition counseling programs among across the countries like in Kenya, India, Ghana, United States, and in the Philippines. So let me Let me focus on in the Philippines integrated antenatal and nutrition counseling. So we are also eager to promote this, the first 1,000 days law, or in Philippines we call it Kalusugan and Nutrition ng Magnanay Act. So it is not only, this program does not only focus on the nutrition side, but also a comprehensive package. Aside from promoting breastfeeding after giving birth, we also provide micronutrient supplementation among pregnant and children. And we monitor the growth of these children up to their second birthday, but not only in the second birthday, but also across all stages of life before they reach the adolescent level. Growth monitoring is followed.
Okay, excuse me, Ma'am Ethel.
Sorry.
You only have another 5 minutes for the presentation.
Okay.
Thank you very much.
So, okay. So let me discuss the last one. So what about the impact of this integration of the primary healthcare? So as we can see here, there is really a significant decline in the maternal and child mortality rate because of the integration, because of the comprehensive program. As we can see in the status of, in terms of breastfeeding and nutrition outcomes, there is an improved outcomes or breastfeeding practices across all countries. And then the other one is in the Philippines. There is a reduced under 5 mortality, and more people are aware of the importance of immunization. But the status for stunting and anemia, it is still a challenge for us. And as of now in the Philippines, LGUs are really eager to participate in the community on the improvement of nutritional status. Okay. So what about our future direction for the for this integration of primary healthcare in relation to nutrition? So better if we strengthen cross-sector collaboration funding. We all know that funding is really a problem for the implementation of the program. And we really need to work with different groups, different departments. And as trend now, the use of digital health solutions or applications can be done in order to easily reach the community. And in the Philippines, our future direction is to enhance local government accountability for the implementation of the programs, scale up nutrition-sensitive programs, meaning the focus programs in order to improve the malnutrition status, invest in the capacity building, meaning training of the volunteers, and promote community-based participation, wherein they have to make sure that they are aware of the culture, traditions of the community, so people will feel comfortable with the intervention provided, and they can also improve their own health. All right. So that's the end of my presentation. Terima kasih, Indonesia. Thank you.
Okay, thank you very much, Ma'am Ethel. Yeah, thank you for your presentation. And ladies and gentlemen, we'll go to the next speaker. Yeah, Dr. Haslina Mukhtar Ajamir. Can you hear me?
Yes, I can. Can you hear me?
Yes, I can hear you. Okay, yeah, thank you very much. Please end the presentation. IT, please end the presentation. Okay, yeah. Ladies and gentlemen, please take notes for the if you have any question for Ma'am Ethel, yeah, because now we'll hear presentation from Dr. Haslina Muhtar Ajamir from Malaysia. The topic is about the impact of primary health care on maternal and child health in Malaysia, and analysis on past and current condition as well as future outlook. Before that, I will read the CV from Dr. Haslina Muhtar, graduated FRACGP from Fellowship of the Royal Australian College of General Practitioners in January 2023, MHFP from Academy of Family Physicians of Malaysia at October 2022, Advanced Training in Family Medicine or ITFM in Academy of Family Physicians of Malaysia in March 2022, and graduated certificate in family medicine in academy same from Academy of Family Physicians of Malaysia November 2017, and MD in Universitas Sumatera Utara, well, from Indonesia, yes, doctor. At August 2008, and BA from University Sains Malaysia at June 2003. And Dr. Haslina as Academy of Family Physicians of Malaysia in 2025 and 2026 as the council member. And there are so many professional rules that Dr. Haslina have. Please continue the next session. Thank you. She also administrative duties in MSU as research group lead in community wellness division from January 2024 till now, and as course coordinator as primary care department of family medicine in MSU also, and also student disciplinary coordinator as primary care department of family medicine in MSU. Yeah, you have three administrative duties, yeah, which until now still in the department I saw. Next, for the works experience, Dr. Haslina is a management and at is a senior lecturer, yeah, at Department of Family Medicine in MSU from August 2020, I'm sorry, 2023 until now, and as pilot international telemedicine project for our of-house clinical consultation to patient under NHS NHS with international accredited family physicians. Yeah, you have so many works experience. I see, Dr. Haslina. Please move to the next session. Okay, Dr. Haslina is teaching at Department of Family Medicine, Management and Science, University, Shah Alam from August 2023 until now, and advanced training in family medicine clinical mentor, AFPM in Malaysia, and di Klinik Kesehatan Anika. Yeah, okay. Also in international. Nah, the research from Dr. Haslina. The latest is about diabetes management in primary care, a scenario-based approach di Akademi Kedokteran Keluarga Malaysia. Yeah. Okay. Please next. The conference. She's joined Wonka in Asia Pacific di Busan and Wonka Asia Pacific di at Singapore. Yeah. Now, for the publication, she has publication about wajah berubah semasa hamil, boleh jadi punca rosaka di Sinar Harian atau Sinar Plus Sihat Aktif di Juni 2025. There are a lot of publication from Dr. Haslina Mukhtar. Next. Okay, there are upcoming events, yeah, Doctor. I think the event is already run at 2000 up September 2025. Okay, next, please, next. Okay. Okay, she also advanced training in family medicine psychiatric module reviewer. Yeah, from Augustus and 2025. Yeah, there are so many experience that Dr. Haslina Mukhtar have. Okay, next, please. Okay, she also joined Management and Science University iNeuron as scientific chair at September 10, 2025. Please, next. Wow, as a professional training, CSMHPCC, cancer pain management training at 18 January 2025. Also community service at Klinik Muhajir volunteer doctor di Kembara Kitchen volunteer. Complementary or minimal com hospice visit for financial challenge. Yeah, I think it is so many experience from Dr. Hazlina Muntar, please. Yeah, please next. Okay, she can speak English, Malay in Indonesia. Yeah, please. Okay, professional training. She has MHPCC. Yeah, Cancer Pain Management Training and Wonka Asia Pacific Conference. Okay, next. Okay. Okay, we may see the reference here, and without further ado, yeah, we can continue to the presentation from Dr. Haslina Mukhtar about the impact of primary health care on maternal and child health in Malaysia, and analysis on past and current condition as well as future outlook. Okay, let's give a warm welcome to Dr. Ajamir.
Thank you very much, Ms. Anggi. Before that, please forgive me. I have a bout of laryngitis, so my voice is a bit husky this morning.
Yeah, that's a little bit slow.
Yeah, I have a laryngitis from influenza A. Do you mind playing my slides, please?
Okay, please. Okay, you may speak slowly.
Okay, so this is the topic of my presentation. I will be speaking on the impact of primary healthcare on maternal and child health in Malaysia. I might refer to it as MCH, but it means essentially maternal and child health. It is an analysis on the past and current conditions as well as the future outlook. Thank you. Next slide, please. This is an outline of the presentation. I'll be taking you through the national healthcare system in Malaysia, and we'll look at the evolution of the maternal and child health services in Malaysia, as well as an analysis of the outcomes and the current practices, as well as the systemic challenges. A bit of a disclaimer: the material presented in this session is for informational and educational purposes only. The statements and opinions are those of the individual presenter. It does not constitute professional advice, nor does it reflect the official policy or position of MSU or MOH Malaysia. I have no relevant financial or non-financial relationships to disclose. Malaysia, Indonesia's neighbor, is a very small country in Southeast Asia. We gained our independence in 1957. Our population is at 32.5 million. Oh, you can't hear me, is it? All right. Terdengar jelas. Our GDP per capita is at 12.37 million thousand US dollar, which puts us in the upper middle income segment in the world. Okay. So a bit of background on the healthcare system in Malaysia. Malaysia operates a two-tier healthcare system. There is a government-run, publicly funded public sector, and a complementary private healthcare sector. The public system is financed by general taxation with no mandatory national insurance contributions. We do not have what you have in Indonesia, ASKES or Asuransi Kesehatan. This model is predicated on the core principle of providing equitable and universal access to care for all citizens and legal residents, with services either being free or subject to very low user fees. The primary healthcare system serves as the first point of contact for the majority of the population. It functions as the first line of defense, focusing on preventive care, early diagnosis, and effective management of disease. This strategic emphasis is designed to reduce the need for more expensive and specialized hospital care, thereby mitigating the burden on tertiary health facilities. However, the success of this affordable public model has led to significant challenges, namely congestion and long queues in the public facilities. This situation has in turn prompted a widespread adoption of private health insurance among the population to gain access to private healthcare providers and pay for treatment at private hospitals or clinics, usually at a much higher cost. However, the market-based private sector steps in to solve the congestion created by the public system's success, thereby creating this complex dual system that ensures universal access and provides a market-driven alternative for those who can afford it. So the measures in MCH that I will be discussing later involve the maternal mortality rate and the infant mortality rate, with the target of making these levels comparable with developed nations. The role of primary care facilities. The network of government health-run clinics, or known as Klinik Kesehatan, and the private healthcare clinics, known as general practitioner clinics, serve as the cornerstone for Malaysia's primary healthcare system. These facilities provide comprehensive range of services for citizens. In the context of maternal and child health, these include pre-pregnancy, antenatal, postnatal, baby and child health services, family planning, and domiciliary care for patients at home. These clinics also function as a hub for health promotion and risk assessment, playing a crucial role in preventive healthcare. Family medicine specialists, alongside medical officers, pharmacists, nurses, medical assistants, and other support staff, work in these clinics and are central to the delivery of MCH services. They conduct face-to-face interviews with mothers, administer self-administered questionnaires on topics such as contraception, vaccine hesitancy, as well as perform physical assessments, including the measurement of height and weight for children under 5. These professionals are instrumental in ensuring the hub for health promotion and risk assessment, which documents a child's health history across various settings. So how did the maternal and child health services come about in Malaysia? So I will be dividing it into two phases. First is the post-independence era, namely the 1950s to 1970s, and then the strategic interventions taken by the ministry to decline mortality indices mentioned earlier in the 1980s to 2010. Next slide, please. Okay. The state of health in colonial Malaya was characterized by a severe lack of public health infrastructure for the general population. In the 19th century, hospitals primarily catered to garrisons and officials of the British Army, and as a result, organized child health as a public health activity was virtually non-existent. High mortality rates were a major problem, with an infant mortality rate of 194 per 1,000 live births recorded in 1920 in the Federated Malay States. The leading cause of death were known to be infectious diseases and conditions stemming from improper feeding and lack of healthcare awareness among mothers. So following Malaysia's independence in 1957, the new government recognized the urgency of this issue and made MCH a priority. Maternal and child health services were established as an essential component of the National Rural Health Development Program. This initiative marked the beginning of a rapid and extensive expansion of health infrastructure. We had 42 primary healthcare facilities in 1956. The government rapidly expanded this, providing the foundational structure for future health intervention. So building on this established physical network, the Ministry of Health introduced targeted interventions to further improve MCH outcomes. These included the maternal and child health programs in the 1950s, the high-risk and safe motherhood initiatives in the late 1970s and 1980s, as well as the confidential inquiry into the maternal deaths in 1990. The CEMD in particular was modeled after a similar system in England and Wales and proved to be an effective audit mechanism for identifying the factors contributing to each maternal death. The success of these programs was heavily dependent on human resources at the front lines, particularly medical officers and nurses. As medical officers were limited in numbers, nurses especially stepped up and played a vital role, conducting face-to-face interviews with mothers, performing child health developmental assessments, and providing essential health education on topics ranging from proper feeding to vaccine hesitancy. The Domiciliary Healthcare Services DHC, introduced in 2016, further enhanced this model by bringing healthcare services directly to the homes of patients, thereby empowering family members and caregivers to continue care after the service period. So let's look at the outcome of these MCH initiatives. First, we will look at the maternal health outcomes and then followed by the child health outcomes. The impact of Malaysia's primary healthcare system on maternal health is evidenced by the dramatic and sustained decline in the maternal mortality rate over several decades. The MMR fell from a staggering 540 per 100,000 live births in 1957 to 28 per 100,000 in 2010. The lowest MMR recorded was 26 in 2011 before it plateaued at 29 in 2017. This improvement is largely attributed to the expansion of rural health infrastructure, which increased the accessibility and availability of primary and antenatal care for women. By 2010, antenatal coverage had reached 98% of pregnant women, and the average number of antenatal visits per woman increased from 6 in 1980 to 12 in 2010. Another significant factor was the increase in safe deliveries attended by skilled health professionals, which rose in parallel with the decline in the use of traditional birth attendants or bidan. The MMR data, while showing significant progress, also reveals the challenge of a persistent plateau in rates since the early 2000s. Okay, let's move on to the child health outcomes. A similar story is evident in child health indices. The infant mortality rate, which stood at 75 per 1,000 live birth in 1957, fell to a single-digit rate of 7 in 2013 and 6.4 in 2019. In 2022, the IMR was 6.7 deaths per 1,000 live births. This significant decline is a key indicator of the efficiency of the healthcare system. The National Immunization Program, introduced in the 1950s, has been a cornerstone of this success, providing mandatory vaccinations against major childhood diseases like measles, polio, tuberculosis, and hepatitis B. The program is structured to provide a series of vaccinations from birth through school age to ensure comprehensive protection. While Malaysia has achieved impressive mortality rates, the country continues to face challenges in meeting global nutrition targets. A major concern highlighted in research is the lack of clear postnatal monitoring strategy for small to gestational age infants in primary healthcare settings. Although antenatal screenings can detect these vulnerable infants, they are often classified as healthy, and we do not yet have the specialized care needed to prevent a higher risk of stunting, being underweight, or developing future metabolic diseases. Next slide, please. A comparative view of Malaysia's MCH indicators within the Southeast Asian context provides perspective. In 2017, Malaysia's MMR of 29 was significantly better than that of neighboring countries in the region. This demonstrates the success of Malaysia's primary healthcare model in tackling foundational health challenges and elevating outcomes above regional averages. However, we cannot be too comfortable. When compared to higher income countries like Singapore, which recorded an MMR of 8 in the same year, a clear gap remains. This comparison reveals that while Malaysia's initial strategy successfully addressed large-scale issues like infectious disease and lack of access, the remaining health challenges are more complex and require a different level of intervention. The current efforts must be enhanced to achieve a level of MCH outcomes on par with the most advanced healthcare systems in the world. Yep, so these are the indices compared to the Western Pacific. In 2017, we can see that while Malaysia is at 29, South Korea, New Zealand, Singapore, Australia, and Japan are achieving better indices. Despite the many successes, several systemic challenges persist. One major issue is the lack of equitable access to medical centers, particularly in rural areas, which are served by more basic public provisions. This urban-rural disparity can lead to longer waiting times and greater inconvenience for patients in remote regions, a problem the government has attempted to address with the development of tele-primary care. Another critical gap is the lack of specific ongoing care for vulnerable groups, such as the SGA infants I mentioned earlier. A review in 2025 by the Department of Public Health UKM found that although antenatal screening can identify these infants, there is still lacking a specific monitoring strategy in primary care setting. As a result, these children are often treated like any other healthy infant, despite their heightened risk for long-term health issues. Another issue is the imbalance of human resources, which poses a significant obstacle to providing comprehensive, high-quality care. While the doctor-to-population ratio is gradually meeting the WHO recommended target of 1 doctor to 500 people, a critical shortage of allied health professionals such as nutritionists and therapists remained. This shortage severely hampers the ability of the healthcare system to provide a multidisciplinary care needed to manage complex cases and address emerging challenges like nutritional deficiencies. Sorry, I was not done with the. So the most profound and concerning challenge is the systemic inequity faced by marginalized populations, particularly immigrants and refugees. Because Malaysia is not a signatory of the 1951 Refugee Convention, refugees lack legal status, which severely limits their access to affordable healthcare. Although registered refugees are entitled to a 50% discount at public facilities, the cost remains prohibitive for most. Okay. So looking to the future, we have gazetted the Health White Paper, which was passed in Parliament in June 2023 in response to these evolving challenges. The HWP serves as a definitive blueprint for the next 15 years to transition the health system from a more disease-centric sick care model to a more holistic, preventive, and wellness-oriented approach. It is structured around 4 key pillars, which I have included in the next slide. Yep. So the 4 pillars are made with the objective of increasing public-private partnership, implementing ICT master plan. We are aiming to shift from treating the ill to ensure people stay healthy, and we want to revise the fee structure to make it more sustainable, as well as restructuring the MOH to creating a national research strategy. Next slide, please. Okay, the rise of AI and tele-primary care system. A key component of the healthcare working plan strategy white paper is to embrace hybrid healthcare and digital technology. The government is already working to counter the lack of medical centers in rural areas through development and expansion of tele-primary care system. This approach leverages digital health technology to refine healthcare delivery, expand access, and optimize processes. The emerging hybrid healthcare model is a strategic response to the systemic challenges of urban-rural disparities and patient congestion. So we are hoping to integrate digital solutions such as virtual consultation and remote monitoring with traditional in-person care. For MCH, this model is particularly valuable, allowing low-risk pregnant women to have virtual prenatal checks and reducing the burden of long journeys to clinics for nomadic or rural populations in states like Sabah and Sarawak. The private sector has also become an active participant, with companies like SpeedDoc, Omach, and Caring offering domiciliary and home-based services, including vaccinations, nursing visits, which complement the public service system, providing additional options for patients. In conclusion, the impact of Malaysia's primary healthcare system on maternal and child health has been transformative. The strategic post-independence focus on building a robust public health infrastructure and implementing targeted MCH programs was instrumental in achieving a dramatic reduction in both maternal and infant mortality rates, elevating Malaysia to a position of leadership in the region. However, this system is now at a critical inflection point. The strategies that brought about the past successes, broadening access and tackling infectious diseases, are currently insufficient to address the more complex systemic and granular challenges that remain. These include a plateau in the key mortality indicators, a persistent lack of equitable access and targeted care for vulnerable groups, and a profound failure to provide inclusive healthcare to marginalized populations. The reforms outlined in the 2023 Health White Paper, with their emphasis on a shift to preventive, digitally enabled, more equitable system, are therefore not just desirable, but essential transformation. The future of MCH in Malaysia will depend on the successful implementation of these reforms, particularly the ability to overcome the challenges of digital integration and human resources imbalances, while simultaneously addressing the deep-seated inequities that threaten the principle of universal and comprehensive health for all. Thank you for your attention.
Okay, thank you very much, Dr. Haslina, for the presentation.
You're most welcome.
IT, please. And yes. Yeah, let's end the presentation. Okay, thank you very much. Okay, ladies and gentlemen, we have listened from the fourth speaker today, and we now continue to 30 minutes Q&A session, and I hope you might raise your hand or type your question in the chat room so I can read it. Please. Okay, Mr. Febri, please raise your hand. Yeah, okay.
Thank you so much for your time. Let me introduce myself before I ask you a question. I'm Febri Sembiring from Laboratory Technology. And I have a question for the first speaker and third speaker. Sorry, I forgot their name. For the first speaker and
Professor
the
Adang.
third speaker.
Professor Adang.
Yeah,
Professor Adang and
and his student, right?
yes, and Mom
Di samping ya kan. Mungkin dia dukungannya mungkin dari apa? Ada 4
okay.
Yeah, Miss Penny.
Yeah.
Okay,
Dr.
Dr. Penny. Thank you, Dr. Penny, for your sharing. It's interesting research and also open my eyes. And I also, especially me, I also hope that it can be here for our leader. So touching our leader's heart to implement your research finding. And for your information, Polytechnic Medan consists of maybe 90% of women gender. And maybe a half of that already have experience in breastfeeding or taking a breastfeeding, right? So however, we didn't have a special room and for taking a breastfeeding and also have a special time for taking a breastfeeding for our employee. And so based on your experience on of your research, what's the most technical obstacle to implement your recommendation in your research? Especially build a safe room or give them more time, more than three months, right? To taking a breastfeeding after deliver her baby. And the second question is, based on your research insight, is creating a supportive community, right? As a man, I really understand that the kind of gender who become obstacle or do a gossip is a woman, right? Sorry. Is it also to be a obstacle of your sorry of your EBF for workers based on your research, and what is your perspective on that matter? That's for first speaker, and then third, and then the second question is for a third speaker from Philippines. For your information, I did a research focus on the kind of pathogens, especially E. coli pathotype, take part and influence a diarrhea child, and then continue to the malnutrition, and also continue to be a stunting child. I wanna share to you that before we talk about nutrition in child, we also have to focus on microbiome affected to the ability of their intestinal absorb that for nutrition in a baby. So is there any specific pathogen exist in malnutrition, stunting, or in a child? If biofilm of bad bacteria made our intestinal, that can be a root of the problem of that problem, nutrition in a nutrition problem. So that's yeah, intestinal cannot be absorb 100% of nutrition after they influenced or infected by the specific pathogen. And in my research, I already get the information that we also find significant pathogen to and influence the stunting of a child stunting. So as a nutritionist, what is your perspective on that matter? Thank you.
Okay, thank you very much for your question, Mr. Febri. Uh, okay, now the first question is for Dr. Penny.
Okay, can I start to answer the very important question from Freddy Sembiring?
Of course, Professor, please.
Okay, first of all, it is important that your campus at Polkes Medan to have room for breastfeeding. So this is a strong recommendation from us, all of us from this meeting, that we should have that for two reasons. One is related to regulation. Two is related to the rights of the woman who breastfeed. Bisa ya, ini dijadikan rekomendasi, our recommendation to the leader of this campus.
Excuse me, Professor, we already have the breastfeeding room in
Oh,
Poltekkes.
okay. So then Freddy doesn't know about that.
Oh, okay. Yeah, maybe we already have the room, but that's not safe for our breastfeeding mom. Thank you.
Okay, so let's improve that way, Bu Agi ya. So still important the recommendation from Pak Freddy ini. Second thing related to room for breastfeeding in market. Dr. Penny will answer that very detailed. In conclusion, it is impossible to have that room in a market. And the third question is related to the empowerment of the husband. Actually, in Indonesia, we do have the kekuatan keluarga, the family resilience. So the husband is really key roles to have a control for exclusive breastfeeding. So, Bu Penny, please give more detailed answer of three questions, or at least the last one.
Okay, thank you, Prof, for the opportunity to me. For the first answer, can I speak in Indonesian
Yes,
to
yes,
share
yes.
it?
Campur-campur
Okay, thank
saja
you.
still because we the all
Okay.
participants for Indonesia.
Oke, pertama kali hambatan dalam pembuatan lactation kernel khususnya di informal sektor ini adalah terkait dengan kebijakan pertama. Jadi kalau Poltekkes sendiri belum mempunyai, nah ini sebenarnya lebih bisa diakses karena peraturan secara undang-undangan ini sudah jelas diatur untuk ruang publik dan ruang kerja workplace. Tetapi untuk kebijakan informal sektor ini yang agak susah dan kemarin pada saat meneliti di pasar tradisional, khususnya di Serdang Bedage, itu sudah ada lactation room-nya, tetapi tidak digunakan semestinya sehingga sampai saat ini tuh masih menjadi gudang. Nah, advokasi kepada pemangku kebijakan ini sudah dilakukan, namun tetap saling, kalau kita bilangnya saling cuci tangan gitu ya, Bapak Ibu. Kenapa? Karena dari dinas-dinas terkait itu merasa itu bukan kewajiban mereka. Dan di sini makanya perlu advokasi lebih tinggi terkait dengan implementasi dari kebijakan menyusui untuk di ruang publik. Karena nyatanya di pasar tradisional sendiri pun dengan mayoritas pedagang perempuan itu masih belum ada untuk support kepada laktasinya. Mungkin itu. Nah, terkait tadi pertanyaan juga untuk suportif tadi ya. Yang kedua tadi pertanyaan supportive community ya, Pak.
Dari mana
Ya,
dia?
ya, betul.
Ya, oke. Untuk supportive community sendiri, ini yang sudah dilakukan dalam studi kami adalah proses pemberdayaan dari kelompok sektor informal, yaitu pedagang pasar. Jadi kami sudah punya grup, tapi belum menjadi komunitas karena memang proses untuk menjadikannya komunitas butuh waktu. Selain dari izin dari manajer pasar, selain itu juga dari dinas pedagang untuk bidang pasar. Dinas Perindustrian. Nah, untuk supportive community yang sudah kami lakukan, ini adalah bekerja sama dengan bidang-bidan yang sudah dilatih untuk fokus konseling eksklusif breastfeeding kepada pedagang pasar yang dimulai dari trimester 3. Nah, dari trimester 3 kelompok ini sudah dilakukan edukasi, dilanjutkan sampai dengan 1 bulan. Kenapa? Karena berdasarkan hasil penelitian, mayoritas ibu-ibu pedagang pasar kembali bekerja setelah 20 hari postpartum. Nah, ini kenapa? Karena memang rata-rata pedagang pasar ini merupakan tulang punggung dari keluarga, sehingga butuh support karena mereka juga kelompok rentan. Dan untuk supportive community-nya, kami berbasis pemberdayaan dengan mengkaitkan program-program yang ada di Puskesmas, khususnya di sini masih Puskesmas Deli Tua yang menjadi pilot studi kami. Dan untuk supportive dari bidan-bidannya adalah bidan PMB yang memiliki klinik di dekat pasar yang sudah dilatih sehingga kami membuat pilot untuk masing-masing pedagang ketika mereka hamil berdasarkan data dari pasar itu pada saat proses edukasinya mulai dari TM3 sudah ada tertuju ke bidan-bidan yang sudah dilatih. Mungkin seperti itu Pak, basis supportive community-nya karena selain itu juga di hasil analisis kualitatif ternyata mayoritas pedagang tidak membutuhkan lactation corner. Justru yang dibutuhkan mereka adalah bagaimana sesama pedagang bisa mendukung untuk menitipkan dagangannya pada saat menyusui. Nah, ini juga salah satu model yang sedang dikembangkan setelah nanti model penny ini sudah bisa diadop dari pedagang-pedagang pasar. Seperti itu barangkali Pak. Terima kasih Prof.
Ya, terima kasih. So, Pak Freddy, those are the results, and I think your suggestion to approach the policymaker so then we can expand the results for policy making in the area and other area in Indonesia. Pak Freddy sendiri, terima kasih banyak.
Okay, thank you very much for the answer from Professor Adang and Dr. Penny. Yeah, the second question from Mr. Febri is to Ma'am Ethel. Please, Ma'am Ethel.
Okay, good afternoon. Good morning. Okay, so the question is, let me repeat the question. Is there a specific pathogen that can cause stunting or undernutrition? Actually, there is in our profession, we don't normally associate directly pathogens and undernutrition, but there are certain pathogens that can cause diarrhea and illness or fever. But this, on the other hand, the effect of this diarrhea or fever can cause malabsorption, or the nutrients cannot be absorbed well fully, or children can lead to loss of appetite if they have diarrhea or infection. So this can now lead to undernutrition. But there's no specific relationship between this pathogen can cause stunting. But the effect of this pathogen, like for example, diarrhea, can lead to malabsorption. And on the other hand, another type of malnutrition is diabetes. I'm sorry, obesity. So for obesity, there is also no such thing, no specific pathogen that can cause obesity or malnutrition, but that this can cause inflammation if there is dysbiosis in our microbiota, and this inflammation can lead to deposition of fats, and that can lead to diabetes. But again, there is no specific pathogen that will directly involve in the stunting status or obesity status. But there are other factors that can lead to stunting or lead to undernutrition and lead to obesity.
Okay.
I hope I was able to answer that.
Okay, thank you very much. That's the answer from Ma'am Ethel. Please, Mr. Febri, is there any question?
Thank you. Actually, um, actually, my question is, sorry. In my research, I find that E. coli pathotype that also influence and have a correlation between stunting and pathogen. There is no specific pathogen, of course, but why we always me as a microbiologist see the fluctuative or the difference uh, mm, the research the research focus on stunting always solving a problem with how we take nutrition, always like that, right? So why the research in Indonesia, and also I don't know in overseas, I see in Indonesia that always focus on only on the how we change or how we improve the nutrition of a child stunting child. So why do we do not focus on what the pathogen, is there any pathogen influence on this stunting affected to the and then absorption or malnutrition of stunting child? Thank you.
Oh, actually, sorry, we don't normally associate it with pathogen because basically in our course, we don't normally focus on the microbiota part and its effect on the pathogen and its effect to nutrition. Our focus is more of the chemical compound that is responsible, chemical compound found in foods, and how this affects the nutritional status. But we, in my experience or in my profession, we don't normally associate the effect of this pathogens like E. coli in the development of stunting.
Okay, thank you.
Okay, thank you very much for the question and the answer. Please, ladies and gentlemen, the next question is from Ma'am Hana. Yeah.
Thank you, Bu Anggi, for the opportunity given to me. I want to ask the question to Miss Ethel from Philippines. Hi, Miss Ethel.
Hi, ma'am. Hi again.
This is our second meeting, actually.
Yes.
Miss Ethel, I want to ask you, in your slide, you have explained that you have 3 core benefits of maternal and child care, nutrition in primary care integrations in Philippines. And one of the core is continuity of care. So my question is, what is your real action or maybe your actual program in Philippines to achieve the target of the core benefit? Thank you.
Okay, basically, our one of the activities is to mobilize the people, the volunteers especially, in order to directly be involved in implementing the intervention, because most people, they are not that fully they do not they are not fully confident sharing their problems, for example, sharing their challenges in improving the nutrition. So one of the intervention is to first mobilize, train volunteers for them to be directly involved in implementing the intervention. And the other one is that we make sure that the services is not only related to nutrition. We also involve other professionals like nurses. We involve doctors in the implementation of the programs, not only for nutrition. So we make sure that we collaborate with other agencies uh, for the delivery of services. Like, for example, for the vaccination, deworming. So nutrition are not in charge of that. So nurses and doctors can do that, while growth monitoring can be done by the nutrition assistants or dietitians. So at the same time, they can deliver services at one time for for mothers or for children that who wants to avail of the services.
So the action is we call with continuity of care, and all the program is funded by government, Miss Ethel?
Yes. Mostly the programs is funded by the government, but we also have non-government agencies who supports the program. Like, for example, companies who can give food, or who can give vitamins or supplements. We're in those items that are lacking, no, lacking in the supplies of the government. So not only government funding, but also the non-government agencies. They also support nutrition interventions.
Okay, thank you very much for the answer, Miss Estelle. Back to you again, Bu Anggi.
Okay.
Thank you.
Thank you very much for
Okay.
the question and the answer. Ladies and gentlemen, I hope you may ask another question. Please raise your hand, or you can type in meeting chat, so I can read it to the speakers. And you may also chat with Bahasa. We will help you to translate it into English. Okay, I see that Mr. Johnson already raised his hand. Please, Mr. Johnson. Hello, Mr. Johnson. Please unmute yourself. Okay, wait a minute. Please help Mr. Johnson.
Okay, thank you,
Okay, please.
Miss Anggi.
Okay.
Yeah, okay. Good noon, everyone. I'm Johnson. I am from Pharmacy Department of Polytechnic, of Medan Health Polytechnic. I want to ask Dr. Penny. As you know, last month we have just done such a community services, Pengmas in Langkat at INE program. So we found that one of the reason of the exclusive breastfeeding failure is doctor suggestion or specialist of obstetric and gynecology suggestion. They are not concerned in I suggest they are not concerned in exclusive breastfeeding. Yeah. Even they suggest that mothers to use formula milk. So, what's your opinion about that? And the second is, maybe I continue my question. I want the answer about that also in Philippines or in Malaysia. And the second question is to Dr. Haslina. I am very surprised that you said that in 2017 that mortality rate in Malaysia is 29, while in Indonesia is 177 177 case. I want to know how long have the Malaysia do the healthcare transformation? As you know, we just have healthcare transformation in Indonesia in 3 years later. Yeah, I want to know how long that the healthcare transformation is done in Malaysia. That's all, Mr. Anggi. Okay, thank you.
Thank you very much for your question. The first
Yeah.
question is to Dr. Penny and also to Ma'am Ethel and Dr. Haslina, Mr. Johnson.
Yeah.
The first question is to everyone here, to every speaker, and the second question is to Dr. Haslina. So, maybe the first answer from Dr. Penny. Okay, please.
Okay, thank you, Mr. Anggi and Mr. Johnson for the question. How to strengthen if the opt gene not support ABF or exclusive breastfeeding gitu ya.
Yes.
And it occur in many region as my place for research in Langkat, Deli Serdang, and Serdang Bedage Regency. So how the tips? It's hard, but we must try. And I just try to many government with links to the informal worker. Maybe Prof. Adang will add my answer. Firstly, we must address the system, not individual. Why? Because if we focus on building systemic accountability rather than blaming individual doctors, in Indonesia, many obstetricians are under pressure to follow hospital routines such as cesarean rates, discharge timing, formula sponsorship, and government can create institutional incentive and regulation that make ABF supportive behavior the default. But from the BFHI or breastfeeding hospital, breastfeeding friendly hospital in Indonesia, it also not occurs in every hospital. And so the second I will inform to Mr. Johnson, we can strengthen interprofessional collaboration. First, we must empower midwives and nurses to provide breastfeeding counseling, even when physicians are neutral or passive. In many hospitals, midwives spend more time with postpartum mother. They can fill the gap if given authority and recognition to give education. And the third, how we make regulate formula marketing and conflict of interest. The key action maybe we must audit formula promotion in hospitals and sanction violation, require public declaration of sponsorship at professional conference, and strengthen collaboration with IDAI and EB to issue joint circulars discouraging formula promotion. And the fourth, we must integrate breastfeeding advocacy into medical and residency training. Why? Because unsupportive attitudes often come from lack of updating training and not resistance. Medical curriculum should include breastfeeding physiology, counseling, and the long-term health impact of formula use. And the fifth, strengthen public accountability and mother empowerment. And the sixth, maybe I recome to policy integration and political will. Finally, embed breastfeeding into broader national goals, position as exclusive breastfeeding as part of stunting prevention, maternal recovery, and economic resilience. It's not just a maternal issue. So maybe my recommendation can be understood for you. Excuse me. Thank you.
Yes, very clear.
Thank
But
thank you.
we wait for the action, Dr. Penny.
Amin. Siap, siap, Mr. Johnson.
Yes.
Insya Allah.
Thank you, Pak Johnson.
Yes.
Actually, your question already discussed in our meeting during the examination, and Penny explained everything. So that's why she got a cum laude degree because of it. Thank you. Go back to Angie.
I want to know how about in Philippines and Malaysia? Please, ma'am. Dr.
Hello,
Ethel.
hello, good afternoon.
Yeah.
Okay.
Yeah.
Actually, I am a breastfeeding advocate, and as a teacher, I'm really motivated and really excited to discuss about breastfeeding. Actually, it's hard. Actually, for example, to inform mothers to practice breastfeeding, especially exclusive breastfeeding, if their community is not practicing on that, or the OB/GYN is not um, telling the mothers to do exclusive breastfeeding. But initially, it's best to here in the Philippines, we have a baby friendly hospital initiative wherein after the delivery, the babies are placed on the side of the mother, promoting exclusive breastfeeding. But after that, we really cannot control in mothers if they will still continue breastfeeding their babies. But the best practice that I can suggest or recommend is that during the uh, prenatal visit, the mother should really be encouraged about the importance of early initiation of breastfeeding within the first hour of birth, and the importance of exclusive breastfeeding and giving another solid foods after 6 months. That's the important strategies that we can give during the visits of the mother in the community. And of course, we really need to train also the volunteers or the health workers in the community about the importance of lactation, the proper way of holding the baby while breastfeeding or while during the latching. So with that, if they have that skills, then we can probably promote the importance of breastfeeding if they really can initiate how to properly breastfeed the babies. Because sometimes the disadvantage or the reason for not breastfeeding the babies is that they are not aware, they are not fully skilled about how to breastfeed the babies. If the nipple is, for example, if the nipple is in pain, or if the milk is not enough. So there should be someone who can tell the mother the strategies that we can do in order to increase the milk, or how to properly latch the babies in the breast. That's all.
Okay, thank you very much for the question, and we'd like to hear from Dr. Haslina, please.
Okay, first on the breastfeeding issue, in Malaysia we have these centers, these policies called breastfeeding friendly centers. This is compulsory for all government facilities and healthcare clinics. Being a breastfeeding mother myself, exclusive breastfeeding for 4 years. No, 4 children, sorry. This is very helpful, but again, why the OBGYN advocated for formula milk, I do not know. That is probably a personal opinion from the OBGYN. Breast is always best, but for me, fed is best. If not all mothers are fortunate to be able to fully and exclusively breastfeed their children, in this instance, resorting to formula milk, I feel is not wrong. Regarding your question on how long Malaysia has been on the transformative path, quoting the report from WHO that was in 2000, that report is actually, it spans about 20 years. It's 2000 to 2017, published in the WHO website. Again, as I mentioned in the presentation, the reform started right from independence itself, building the infrastructure first and then having the policies to support the infrastructure. So I would say it's been long coming since independence. Did I answer your question, Mr. Johnson? You're muted. I don't know.
Please unmute yourself, Mr. Johnson. Please help Mr. Johnson. Okay.
Okay, thank you, Miss Anggi.
Yeah, is that enough? I guess.
Yes, enough, Miss.
Okay, thank you very much for the question and the answers. Yeah. We go to the next question. I see Mr. Haripin already raised his hand for a long time. Please, Mr. Haripin. Please spotlight Mr. Haripin. Hello, Mr. Arifin. Okay, Mr. Haripin. Yeah. Help Mr. Haripin to unmute himself, please.
Okay, thank you.
Okay. The question, please.
Okay, thank you, Miss Anggi. Welcome to Indonesia Italianas. Hello, hi, and other speakers. Okay, my name is Saripito Sinaga. My background in community nutrition is interesting to discuss with Mom Ethely May Onas from Philippines. Hi.
Hi, sir. Good afternoon.
Okay. Seems you have to want to step ahead in breastfeeding program. You early adoption the milk code Philippines, as I understand. And the unique one is you including up to 36 months in preventing the commercial milk formula. I'm interesting to understand how your government to manage this WHO code in your country.
Uh, Actually, sir, for the milk code, they are very strict in implementing this milk code, especially nowadays that here in the Philippines, we are always experiencing disasters, like, for example, flood and earthquake. So with that, we really implement that in terms of the giving of food during emergency feeding. So we do not allow giving formula milk, especially those with formula milk for babies. And if they we really have to check if companies who are donating foods, they are not allowed to donate milk or any milk related products, because this can promote the use of formula milk, especially for mothers who are breastfeeding or who have babies or infants. So those are basically the practice that we use here in the Philippines.
Okay, thank you. But specifically, I want to know, is it that your country prohibited, prevent the children up to 3 months not to drink formula milk?
Um, Actually, we cannot control those mothers who give formula milk. It's up to them, but we don't strictly tell them that you are not allowed to this three these children are we don't implement this that they are not allowed to drink formula milk, but it's up to them. But during the donation, then that's our part we took part on that we don't allow donations on the giving of milk, but for the personal use of each mothers or for their babies, then we cannot do something on it, and we have no specific law prohibiting mothers to use formula milk for their babies.
Okay, thank you. The last questions.
This is all about more of
Okay.
this is more about for promotion only. Okay, thank
Promotion
you.
only. Yes, because I'm thinking because in WHO is 20 months over is is allowed to drink formal milk. But this is
Mhm.
another point that I want to ask about the school feeding, so the school lunch or
Uh,
school food. Indonesia just started, we call it free food program, free nutritious food
mhm.
program. And current time, we have like a mass poisoning food in Indonesia. And I see in your slide, you have like a not so complicated platform in implementing school food programs. Any we can how can you explain that we want to listen to learn how Philippines to manage and control the school food program in your country?
Okay. So in relation to the implementation of safety food for children, we
Yeah.
make sure that during our planning, we make sure that foods that we are going to prepare and serve to the children are not or those foods that can be controlled in
Mm.
terms of the growth of the microorganism. So we make sure that we don't prepare foods that can be easily get
Poison.
uh, poison that can produce pathogens.
Yeah, but
So foods that are more of dry,
mm-hmm.
uh, for
Right.
example, fried foods.
Right. Food.
Uh, we don't normally include milk-based
Oh,
products
I
in
see.
the food, and those containing tomatoes because they are easily get stale
Yeah.
during the preparation. So basically, the ideal food for feeding are foods that are that can prevent the growth of microorganism. More on foods that are dry without the presence of the use of milk and the use of tomatoes,
Mm-hmm.
and it should be properly prepared by using gloves, or we avoid contamination of food during preparation, because we all know that children are susceptible to illnesses, so we make sure that the foods that we will prepare will not get easily spoiled.
Okay, I see. You have
Mhm.
time, Mom? Do you
Yes,
still have
sir.
time for me?
You
I'm
still have,
sorry.
Okay.
I think Mr. Haripin already get the answer, yeah,
Yeah,
from
because
matter.
I'm a community nutritionist, seems with the Atleonas.
Yes,
The
of course.
same.
Nice meeting you, sir.
Nice meeting to you, Anas. Yes.
Okay, very interesting question, yeah, but MBG, yeah, Mr. Haripin,
Yeah.
Indonesia. Okay, ladies and gentlemen, the last question, please, because the Q&A session already runs about 40 minutes. Please raise your hand or type it in chat box so I will read it to the speakers. Okay, please.
Apa namanya? Spotlightnya guys, spotlightnya. Spotlightnya Pak Arifin awas.
Okay, yeah, seems there are no more questions from the audience. Please, you may ask directly or you just can type in the chat box. Ladies and gentlemen. Okay. Please pin the other speaker, IT. Please pin the other speaker so we can give closing statement.
Summarize, bukan dia statement dulu baru aku summarize terakhir. Ya kan? Atau aku summarize dulu?
Yes. Yeah. Okay.
Sama aku lah satu lagi.
Okay, thank you very much, IT, for spotlight us in this Zoom meeting. Okay, ladies and gentlemen, I think we've reached the end of this session, and I hope the speaker can give a closing statement. The first speaker is from Dr. Penny mungkin that represent Professor Ada. Please, Dr. Penny.
Okay, thank you for the opportunity. My closing statement for my topic today, exclusive breastfeeding begins with a mother's decision, but its success depends on how we, as a community and as a system, support her. Let us work together to create environments where where every mother, no matter where she works, can give her baby the best start in life. Thank you very much for your kind attention.
Oh, that's so good. I'm very agree with you. Yeah. For the participant, you may use the button, please. So the seminar will feel live and more colorful. And the second, I please to Ethel to uh, please say your closing statement.
Okay, so good afternoon once again. So I'm Ethel Anyas. I'm a registered nutritionist dietitian, and as a health professional, it is really important that we integrate primary health care and nutrition in a holistic manner or holistic care. And we combine nutrition services with immunization, disease prevention, um, supplementation, in order for us to ensure better health outcomes, because no single intervention can lead to better health status. So meaning we really need to integrate other healthcare services in the community in order to strengthen our health system.
Okay, thank you very much, Miss Ethel. And the last one from Dr. Haslina. Please say your closing statement.
Hi, good afternoon. So my takeaway message is the importance of primary healthcare in all healthcare systems. If you want to strengthen and change the health of the entire country, it has to begin from primary care. Thank you.
Okay, thank you very much, Dr. Haslina. Hope you get well soon, yeah, doctor. Okay, ladies and gentlemen, I will uh, read the conclusion of this first session of for international. The first speaker says that exclusive breastfeeding among informal workers in North Sumatra is hindered by structural and cultural barriers. A multi-sectional policy-driven approach combining infrastructure, education, and health service integration is essential, of course, to improve the ABF rates and maternal child well-being. And the second, from Dr. Nola, the conclusion stress continue promoting
of enabling factors such as family support and respectful care to ensure effective perinatal service to adolescents, mother during and beyond the pandemic. Okay, comprehensive health education and positive patient provider relationship are key to improving adolescents' maternal and child health. Of course, the third from Miss Ethel. Okay, the presentation advanced a holistic approach to maternal and child nutrition as a foundation for improving health outcomes and sustainable development, aligning with global committees like the Sustainable Development Goals and universal health coverage, maternal and child health nutrition, Sustainable Development Goals, universal health coverage, and the last from Dr. Haslina, primary healthcare system has had a transformative impact on MCH outcomes in Malaysia. Continued reforms aiming at prevention, equity, and digital health will be essential to sustain and further these gains in maternal and child well-being, maternal and child health white paper, primacy care, and universal health coverage. Okay, that's all, ladies and gentlemen. For the closing statement, let me say pantun, yeah. Please, I will speak in bahasa and try to translate it in English. Okay, please cakepnya ya. Mentari senja tenggelam perlahan.
Cakep.
Meninggalkan jejak cahaya jingga.
Cakep.
Ilmu yang bermanfaat telah kita dengarkan. Tetap semangat, masih ada sesi selanjutnya.
Cakep.
Okay. I'll try to speak in English. This evening sun slow sets, leaving trace of amber light. We've gained valuable knowledge, so keep your spirit up to the next event.
Great.
Okay. Satu lagi ya Bapak Ibu. Ibu hamil pasti perlu nutrisi untuk perkembangan si buah hati. Saya Anggi mohon undur diri, salah dan hilaf mohon maaf dari hati. Oke.
Cakep.
Okay, I will translate it in English. Okay, pregnant mothers need proper nutrition, of course, for the baby's growth and well-being. I Anggi, hereby take my leave. Please forgive any mistake or faults from me. Okay, once again, thank you very much for joining us virtually, and thank you very much for the great speakers. Yeah, wishing you a productive and pleasant day ahead. Wassalamualaikum warahmatullahi wabarakatuh. Good day, everyone. Bye.
Ibu. Thank you,
Give
Bu
it back to
Anggi.
Mr. Hana.
Thank you, Bu Anggi, for guiding this first session of conference. Ladies and gentlemen, we will express our gratitude to all the best speaker today. Would you mind to give a emoticon react, to click the button of react, please, to give the gratitude for all the speakers today. Thank you very much for having you. And we are so blessed for having you in our international conference. Thank you very much for being our speakers today, Prof. Adang and Dr. Penny from Indonesia, Dr. Nola Holness from Florida, United States of America, Miss Ethel from Philippines, and Dr. Haslina from Malaysia. Your insight and expertise has been truly inspiring and valuable to all of us in this event. We deeply appreciate the time and effort you have taken to all of us in Medan, of course, in Medan Health Polytechnic of Ministry of Health. And we see you again in another good event. Thank you very much, our best speaker today. So, ladies and gentlemen, we will have a break session for 1 hour. After the break, we will have the second conference today. And see you again at 1 p.m. And wish you have a great lunch, ladies and gentlemen. Thank you, everyone. We will have a break session.
Okay.
Thank you.
For all the participants, please don't forget to fill the list of attendees that we have submit in chat room. Sorry. We have sent in all link tree. Maybe in WhatsApp group you have show the link. Please don't forget to fill the list of attendees.
See you again, ladies and gentlemen, at 1:30 p.m. Thank you very much. Sekarang? Yeah. Until 5. 1:30 hours. No, I wouldn't.
Politeknik Kesehatan Kementerian Kesehatan Medan terletak di kota Medan yang merupakan ibu kota Provinsi Sumatera Utara. Kota terbesar ketiga di Indonesia dengan penduduk lebih dari 2 juta jiwa atau sekitar 2.460.858 penduduk. Politeknik Kesehatan Kementerian Kesehatan Medan sebagai satuan kerja Badan Layanan Umum yang berada di bawah Direktorat Jenderal Tenaga Kesehatan Kementerian Kesehatan Republik Indonesia. Lokasi Direktorat Politeknik Kesehatan Kementerian Kesehatan Medan terletak di Jalan Jamin Ginting kilometer 13,5, Kelurahan Lauci, Kecamatan Medan Tuntungan, Sumatera Utara.
Visi Politeknik Kesehatan Kementerian Kesehatan Medan adalah menjadi pusat pengembangan teknologi kesehatan yang unggul dan berdaya saing global tahun 2044.
Poltekkes Kemenkes Medan merupakan unit pelaksana teknis dari Kementerian Kesehatan yang berada di bawah Direktorat Jenderal Sumber Daya Manusia Kesehatan yang melaksanakan fungsi Tridharma perguruan tinggi, yaitu pendidikan, penelitian, dan pengabdian kepada masyarakat. Secara administratif, Poltekkes Kemenkes Medan dibina oleh Direktorat Jenderal Sumber Daya Manusia Kesehatan Kementerian Kesehatan Republik Indonesia. Secara teknis dibina oleh Kementerian Pendidikan Tinggi, Sains, dan Teknologi. Sedangkan secara keuangan dibina oleh Dirjen Pembendaharaan, yaitu pola keuangan dengan Badan Layanan Umum.
Adapun misi Politeknik Kesehatan Kementerian Kesehatan Medan, yaitu menghasilkan lulusan yang kompeten, berdaya saing nasional dan global, menyelenggarakan penelitian dan pengabdian masyarakat berbasis teknologi kesehatan di tingkat nasional dan global, menyelenggarakan tata kelola dan iklim akademik yang baik, mengembangkan kemitraan strategis dengan pemerintah, industri, serta institusi nasional dan global.
Secara administrasi, Poltekkes Kemenkes Medan dibina oleh Direktorat Jenderal Tenaga Kesehatan dan secara teknis dibina oleh Kementerian Pendidikan Tinggi dan Sains Teknologi. Secara tata kelola keuangan, BLU dibina oleh Kementerian Keuangan. Politeknik Kesehatan Kementerian Kesehatan Medan telah terakreditasi B oleh Ban PT dengan SK nomor 965/SK/Ban PT /PT/PT/9/2023 yang terdiri dari 18 program studi, yaitu program studi Diploma 3 meliputi farmasi, kesehatan gigi, teknologi laboratorium medis, keperawatan Medan, keperawatan Gunung Sitoli, keperawatan Tapanuli Tengah, keperawatan Bali, kebidanan Medan, kebidanan Pematang Siantar, kebidanan Tapanuli Utara, gizi, sanitasi, program sarjana terapan kesehatan yang meliputi keperawatan Medan, kebidanan Medan, sanitasi lingkungan, serta gizi dan dietetika. Pendidikan program profesi bidan, pendidikan program profesi nurse, penambahan program studi lain di bidang kesehatan terus diupayakan.
Saya melaksanakan tugas direktur dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat sehingga menghasilkan lulusan kompeten di bidang kesehatan yang mampu mendukung transformasi kesehatan di Indonesia.
Saya melaksanakan tugas direktur dalam bidang kemahasiswaan, alumni, dan kerjasama. Untuk bidang kemahasiswaan dan alumni, kita memberikan layanan mulai dari proses penerimaan mahasiswa baru sampai dengan wisuda, dan juga untuk alumni dalam hal pendayagunaan lulusan Poltekkes Kemenkes Medan. Untuk bidang kerjasama, kita melaksanakan MOU dan MOA, baik instansi dalam maupun luar negeri, dan juga kita bekerja sama dengan Badan Eksekutif Mahasiswa dan juga unit kegiatan kemahasiswaan dalam kegiatan kampus dan juga berpartisipasi dalam event nasional dan internasional.
Dalam rangka menunjang kegiatan pembelajaran teori dan praktik, Politeknik Kesehatan Kementerian Kesehatan Medan didukung fasilitas seperti asrama, laboratorium terpadu dan jurusan, laboratorium komputer dan ruang CBT, laboratorium bahasa berstandar internasional, perpustakaan terpadu dan jurusan, auditorium, klinik pratama terakreditasi paripurna, musola, lembaga pengembangan kompetensi terakreditasi A, sarana transportasi seperti bus, hiace, mobil dinas, podcast, sarana olahraga seperti mini soccer, lapangan bulu tangkis, voli, dan sebagainya. Sehingga lulusan Politeknik Kesehatan Kementerian Kesehatan Medan siap bekerja di bidang kesehatan. Mari bergabung di Politeknik Kesehatan Kementerian Kesehatan Medan. Unggul, kompetitif, profesional.
Apakah teman-teman tahu, korupsi dan gratifikasi adalah permasalahan serius yang dapat merusak bangsa ini? Membuat pelayanan publik menjadi kacau, akses pendidikan yang tidak merata, merusak iklim investasi dan menyebabkan ekonomi biaya tinggi. Menyebabkan diskriminasi dalam berkarir dan sulitnya mengejar prestasi di kancah dunia. Karena itu, mari kita semua bersatu untuk memutus mata rantai korupsi dan gratifikasi. Jadilah pahlawan integritas dan hapuskan diskriminasi akibat korupsi. Berjuang untuk bebas dari korupsi dan gratifikasi. Karena bangsa merdeka adalah bangsa yang adil dan sejahtera. Wujudkan Indonesia merdeka tanpa korupsi dan gratifikasi.
Oh, cek one, tes 1, 2, 3 dicoba cek. Cek. Kak Amira, am I audible? You can give your thumbs up, please. Thank you so much for the reaction. Ladies and gentlemen, we will move to the next session. Before we start our session, I would like to give a warm welcome to all our distinguished speaker today. Would you mind to spotlight the speakers, please, IT committee? Yeah. Welcome Bu Fitri Widyaningsi. Welcome Miss Leo Becker from WHO. And how about Bu Masra and Pak Haripin of cam? Would you mind to open your camera, please? Okay. Okay. Ladies and gentlemen, the first session of the 4th International Seminar of Medan Health Polytechnic of the Ministry of Health 2025 has been completed. Now we move to the next sessions. We will have a best and important material that will be delivered by our distinguished speakers today in this second session. We will hear the important material from Dr. Fitri Widyaningsih, MS PhD from Indonesia, Ms. Leontine Becker from RM in RMNCAH WPRO or Reproductive Maternal Newborn Child and Adolescent Health from Western Pacific region from WHO, Bu Masrah SPDMKes from Indonesia, and Dr. Haripinto Gapsinaga MCN from Indonesia. Ladies and gentlemen, this session will be guided by Pak Febri Sembiring, Master of Science. Without further ado, we invite Mr. Febri to the screen now. Welcome, Mr. Febri. Thank you for your cooperation.
Thank you, Miss Hannah, for your inviting me to this conference. Yes, good afternoon, everyone, ladies and gentlemen. Welcome to the 4th International Conference of Polytechnic Medan. Now we are entering the second session, which will run start from now until 5 p.m. And I'm Febri, gonna lead this session. In this session, we will listen the presentation from our distinguished speaker, who will share their research and knowledge experience related to the theme of our conference. Before we begin, I would like to kindly inform all speakers that Q&A session will be conducted after the fourth speaker has finished the presentation. So please note that all of our presentation will be delivered first, and then we'll proceed to the discussion and question session together in the last session of this section. So let's begin our session for the first speaker. And I would like to invite Dr. Fitri Widyaningsih as a first speaker. Hello, Dr. Fitri. Dr. Fitri, you are not audible. Sorry, wait a minute to...
Yeah, thank you. Good afternoon, everyone. Good afternoon, Pak Febri.
Thank you for joining this conference, Dr. Fitri. Before I give the session to you, let me read your CV anyway. She is from University of 11 Maret, yeah, Head of Doctoral Program in the Public Health, Faculty of Medicine, Universitas 11 Maret, Surakarta, Indonesia. Associate Professor in Social Epidemiology, Universitas 11 Maret, Surakarta, Indonesia. And she graduated in epidemiology from USA. And she has a respected academic and research with expertise in epidemiology from USA. And she has been published many research in reputable publisher and journals. And today she will present her topic. Committee, please share. I already read all the CV. Can you skip to the first slide of presentation before we begin? Okay, before I read the her topic, I would like to greeting Ibu Dr. Fitri. Hello, Ibu Dr. Fitri. How are you today?
Hello. I'm
Hello.
good. Thank you. Good afternoon. Good afternoon, everyone.
Welcome to Polytechnic Medan. Is it your first time to have a
Thank
conference
you.
in Polytechnic Medan, Ibu?
Yes, this is my first time. Thank you for inviting me.
Thank you for give us this good opportunity to join this conference, Ibu Dr. Fitri. So she will present her topic entitled about minimize, please. Okay. Strengthening integrated primary health care in the maternal and child lesson learned from ultrasound implementation in Indonesia. So Dr. Fitri, time is yours now. Thank you.
Thank you. Thank you very much. Before I start, can I confirm that everyone can hear me clearly?
Yes,
Okay.
Yes, you
Okay,
are.
thank you. Thank you very much. And if you don't mind, I would like to share my screen so that I don't ask the IT department to go to next slide.
Yes, you do.
So
Yes,
let
you
me
do.
share my
Okay.
screen.
Okay.
Thank you. Okay. So first of all, thank you for inviting me to this conference and also for inviting me to Polytechnic Medan. This is my first actually to come to Polytechnic Medan, although albeit virtually. Hopefully, I will be able to come to Polytechnic Medan in the future, offline directly. So today, as the moderator already shared, I'm going to present our research on ultrasound and how this ultrasound implementation influence integrated primary healthcare in maternal and child in Indonesia. And I present this on behalf of the ultrasound implementation research team. We did this research in 2023 and 2024, and Poltekkes Medan is actually one of the collaborator for this research. So thank you for Poltekkes Medan. For today, I will have several subtopics. So first, we're going to review regarding maternal and child deaths in Indonesia. I'm sure everyone already familiar with this topic, but we would like to see how it is now and how is the trend. And then I'm also going to take us to review again the integrated primary care or IPC in the context of maternal and child health, how the maternal and child health care influenced by IPC. And then we would then discuss about the case study, which is the implementation of ultrasound in strengthening maternal and child health in Indonesia. And for this case study, I'm going to share related to coverage and also utilization of ultrasound, and then barriers and facilitators, and of course, lesson learned. So let us begin by reviewing this slide. I'm sure you are familiar with this slide, how we are still among the top countries for maternal and child deaths in globally. And among Asian countries, as you see here from this graph, we are also still among the top countries for maternal death. And we are also still lagging behind for infant death. We have this target for 2029 to achieve 77 for maternal death, so 77 over 100,000 live births, and less than 10 for infant deaths. So when we're looking at this very low number, we need to think not only about access, which is something that we think when we have still very high maternal deaths as we have before, but now we need to also think about the quality, because this is the harder to address problems. These pregnant women, these mothers, this infant, they might already come to primary care or they already come to the hospital, but they will need the quality healthcare to improve and also to be able to survive. So these are the challenges that we are facing now and the difference of what we faced few years ago. Another problem that we see is this picture. So we still see disparities in our countries. Our countries is very wide, very large, and various. So if you think about intervention in Indonesia, you need to also think about the diversity of the geographical location, resources, culture, and that's also happened in maternal mortality. So we still see these inequalities persist across provinces in Indonesia. So this dark blue show that the maternal mortality is higher compared to this lighter blue province that we see here. And this is concentrated especially in eastern Indonesia. And then another problem is also the disparity due to wealth and socioeconomics. And this happens not only in maternal mortality or in infant death, but also in other problems related to maternal and child. One of the problem is poor access for the poor households. And another thing is also because of the financial capacity of these poor households. So when we think again about the maternal death and also maternal infant death, we also need to see what type of problems that we are addressing. So for maternal deaths, there are several problems. So here, this is data from MOH, and we are listing top 5 of problem for maternal deaths and top 4 for infant deaths. And if we see here, these problems are actually problems that can be considered modifiable. So hypertension in pregnancy, non-obstetric complication, which generally due to comorbidities with other disease, and then obstetric hemorrhage, those are the things that can be screened earlier and then treated also earlier and adequately. So here are the opportunity for us to be able to address this problem and reduce maternal deaths. For infant deaths, the problem is mostly due to respiratory and cardiovascular disorder, low birth weight, which is also modifiable. If you think about malnutrition and also think about how we're going to intervene from teenagers to premarital women, then this is something that we can actually reduce. Same thing with infection. So based on this picture that we already see, the high maternal mortality and also infant mortality, the type of maternal deaths and infant deaths cause, one important strategy that we need to improve is actually to have coverage and quality of maternal and child health care. So here I emphasize that we not only need to improve coverage, but also need to improve the quality of maternal and child health care that is received by pregnant women and also their children. And this needs to be continuous, so continuum of care from preconception, antenatal, delivery, and postnatal, both for the mothers and also for the children. So I'm going to take you through this. In 2021, the government of Indonesia launched the integrated primary health care, and this aims to improve the health system to be more resilient, equitable, and also accountable. And for maternal and child health, this is included in cluster 2. So one important strategy is actually to strengthen in primary health care and also to improve maternal child, which is in cluster 2. So how do we improve maternal and child health? There are several things actually that already have become the priority of the MOH right now. So first, it starts from preconception. So preconception screening, as we know from previous graph, previous slide, it's very important to understand the comorbidities that can happen to the pregnant woman. So here, screening for comorbidities, health education, identifying high risk and specific condition even before antenatal is very important. And then when you come to antenatal care, we need to also see there are several components that right now added into integrated care. So prior we have 4 visits, now we have 6 visits. First visit in the first trimester, second and third in the second trimester, and then you have additional 3 visits in the third trimester. And I heard that next year is going to be into 8 visits. So we're trying to improve the frequency of antenatal care visit, but not only in the improvement of
Okay, we are waiting for Ibu Dr. Fitri for a technical issue. Wait for a moment. All the audience, am I audible? If I'm audible, please give a response from chat column. Am I audible? Is there any technical issue in our conference or from Ibu Fitri?
You are audible. Yes, you are.
Okay, thank you, Miss Baker.
My apology. I think my internet connection was not stable. I hope it's more stable now.
Yeah.
Yeah, okay. Pak Febri, can I confirm where did I lost my signal in which slide?
Okay. Can you
This
share the
one or
slide?
previous
Then I
one?
can.
Okay. Okay, I will start with this
Yeah.
one then.
Next
This
slide.
one. Okay.
Yeah.
Okay, thank
I
you.
think
So,
that's gonna be start. Yeah, yeah. Okay. This slide.
okay, I hope this slide. Okay, I will just emphasize on this integrated antenatal care. So previously we have 4 visits, now we have 6 visits, and then in the future we will have 8 visits as what the WHO recommended. But in addition to the frequency, there's the importance of adding component of antenatal care. So this now we have 12 components of a standard antenatal care, and these include ultrasound and also mental health screening. And this will be followed by facility delivery, postnatal care, which now we need to have 4 postnatal care for mothers, including the 3 visits for babies, and then neonatal screening, which is also something that we add for the IPC, and then basic obstetric and neonatal emergency care in Puskesmas. So I'm going to take you through the case study. As we learned from previous slide, ultrasound is one of the things that we need to include now in the antenatal care component. So this study we did to evaluate how the implementation of ultrasound in primary care or puskesmas in Indonesia. So why ultrasound? The WHO recommends routine ultrasound during pregnancy, and this is particularly before 24 weeks of gestations, to screen for comorbidities, to screen for abnormalities, and to make timely referral. So this is why it's very important to include this and to have pregnant women able to access this. Globally, ultrasound examination is also considered key element in routine antenatal care. For Indonesia, the MOH regulation in 2021 already stated that for antenatal care visit, there will be 2 visits with doctors, and that include ultrasound. Generally, it is recommended in the first and fifth visit. And based on this regulation, starting in 2022, the MOH already deployed ultrasound to puskesmas in Indonesia. And by end of 2023, 93% of puskesmas already has ultrasound. And by end of 2024, 98% of puskesmas has ultrasound. And we're going to see how it implemented and how it affects child and maternal health. So how did we evaluate the ultrasound implementation? So we aim to assess, the first is fidelity, so coverage and utility of ultrasound. And the second is feasibility. This is facilitator and barrier. We did a mixed method study. So we have online survey to puskesmas and trained doctors in Indonesia. And then we have qualitative study. This is focus group discussion and in-depth interview. In North Sumatra, we went to Deli Serdang and Pematang Siantar. In West Java, we went to Bogor and Cianjur. And in East Nusa Tenggara, we went to Kupang and also Manggarai Barat to have different point of view of the different location in Indonesia, representing Java and then Sumatra and also the islands in Eastern Indonesia. So how is it implemented? As I mentioned before, 98% of puskesmas actually already have ultrasound, but only 82% have utilized ultrasound for antenatal care. And when we look further, it's because 6% turns out that ultrasound was not in a good condition, so they cannot use it. And then there were also reasons due to lack of trained doctors. So there are puskesmas with ultrasound, but they don't have doctors to perform the ultrasound. And then also limited resources. So that's why only 80% of the puskesmas that have that we collect data from already use ultrasound. How is it used though? So for this, from the around 1,700 puskesmas that we collect data from, they generally perform ultrasound monthly for 32 pregnant women. So these 32 pregnant women include those pregnant women in the first visit, around 15 pregnant women, and then 17 pregnant women in the third visit. We also try to explore, so some of the puskesmas actually open the ultrasound examination 1 to 2 weeks per day, 1 to 2 days per week, sorry. And this is most of the puskesmas. 15% open 3 to 4 days per week, and almost 30% actually opens almost every day. So we try to compare how the number of days they open for ultrasound relate to the number of pregnant women that they covered. And this is what we found. So this blue one is the pregnant woman that they that come to puskesmas to have antenatal care, but they did not have ultrasound. And this is because they come maybe at second, third visit or fourth visit or the last visit. But for the first visit or the first ultrasound in the first trimester, we see slight increase when we add the number of days. So it's additional 2 pregnant women that can be served. And then when we look at here, this is also slight increase, additional 2 pregnant women with additional days that they open for ultrasound. And then we try to also assess how is it used by looking at number of days and what is the cause of those opening days. So we identified that one of the important thing influencing the number of days for ultrasound service is the number of trained doctors. When you only have 1 trained doctors, most of the puskesmas they open only 1 to 2 days. So 63% only open 1 to 2 days. But when you have 2 doctors, more puskesmas, so 36% open 5 to 7 days, only 46% open 1 to 2 days. And then when you have more doctors, you see that they are more likely to open almost every day. So here we see the importance of human resources, especially trained doctors in opening days for ultrasound. And then we also would like to see at that time what changes. So what happened after we implement ultrasound? And this is data from MOH. So this blue bar here is showing the visits with ultrasound. So this is the first visit in 2022. We still see very small from all pregnant women, 31%, and it improved to 50% in 2024. And what we think very important as well is this yellow gap. So this yellow showed pregnant woman coming for their first visit but doesn't get ultrasound examination. So from 9.4% in 2022 to only 1.3% in 2024. And then for fifth visits, here for the third trimester, the number also increased for the number of pregnant women with ultrasound. And then the number of the pregnant women coming for their fifth visits but doesn't get ultrasound also decreased. So this is showing higher quality and also higher coverage of ultrasound examination among pregnant women. And then from the qualitative data, we see that we learned that there is increasing motivation and enthusiasm of pregnant mothers, especially from poorer and also rural remote area, those that before this ultrasound was implemented in Puskesmas, they cannot get access to ultrasound, and now they can have it. So ultrasound help detect abnormalities, and it can help the doctors and also midwife and the pregnant woman to plan the delivery easier. We look also at what changes in terms of output. So one of the things very important for ultrasound is how it can revert timely. So make screening earlier and then revert timely earlier as well. So this is the number of Puskesmas that reported they have referred patients with this condition. So we see that in the first trimester, these are the conditions that before ultrasound might not be able to be detected early in Puskesmas, but because we already implement this can be detected earlier. And same for the referral in the third trimester. So some condition that might be more difficult without examination with ultrasound, we can detect faster and it can be referred timely. So this is from the qualitative data. So early detection increase and faster in detecting and also referring high-risk cases, and very helpful, especially for the underprivileged, and to make a referral to hospital. So we look into the third components that we want to see for ultrasound implementation, which is the barriers and also also facilitators. For facilitators, these are the one reported. So training of doctors, competency of doctors, and then OBGYN supervisions, mainly human resources are the things that very important for implementation. And then telemedicine, interestingly, is also important in implementation. So here they also mention from qualitative regulation from the MOH, very important to facilitate the rollout of this program. And then the next is barrier. The number of doctors, as we see before in previous slide, and then quality of ultrasound. So this ultrasound is actually the two-dimension ultrasound. So those are the things that sometimes might be more difficult for the primary care doctors to use and also to be able to detect and diagnose. And then doctors' components, and then there are problems in terms of resources as well. So when we look into the qualitative is also support our quantitative. The number of doctors is still lacking, and then there in some places there are unavailability of doctors, especially in rural and remote area, and then completeness of the equipment, and then they also mention regulation related to BPJS claim. And one of the thing also we learned from observation and qualitative data is the recording and reporting system, which is not yet integrated into the antenatal care reporting system. So this is just an example of how the recording and reporting at Puskesmas. So they have plenty of books and manuals and system that they need to fill out for one patient. So we also at that time want to see how's the doctors then, because doctors are very important here, including the support system, midwife, nurses, and also the infrastructure. So we look at the doctor's perception of their competence in doing ultrasound, and these are the high score that we receive. So most doctors feel confident when doing referral and then seeing the indication for ultrasound first trimester, third trimester. But we also look at others' competence like pre-eclampsia screening and malnutrition screening. And we see that here the doctors already feel they are confident enough. And based on our qualitative study, we found that most of the doctors trained have also on-the-job training. So we think this is important in improving the doctor's perception of their competence. However, there are some variations in the training. So most of the doctors, they receive 4 to 7 days of training. Others, 1 to 3 days. And then there are around 18% that receive training up to 2 until 4 weeks. And we see from the qualitative exploration that doctors who have more training, they are more confident in providing care with the ultrasound. When we look at the low score, so this is when we ask the doctors, how is their perception? And then we try to see the low score, so whether they are still not confident enough, in which area that they still feel not confident in doing the antenatal care, especially ultrasound. So this is what we found. They feel that they still need adequate training, and there are several conditions that they feel low perception of competence. For example, for extrauterine pregnancy and then amniotic fluid detection, trying to summarize the abnormal finding and then abnormalities of placenta location, fetal death, fetal weight, and then multiple pregnancy. These are the things that some of the doctors reported they still need more training and also more guidance. So we explore further that these doctors, they have manual book, 60%, and then a third of them actually learn from other resources as well. So we see the link from previous slide, they need more updates and also training, and then they try to seek training and also updates from other resources. And interestingly, 49% conduct telemedicine through WhatsApp. And this is something that we found in the qualitative study very important as facilitators for successful implementation of ultrasound. So based on this finding, what can we learn? We found that in Indonesia, this access has increased dramatically, especially for underprivileged population. And we found from our quantitative and qualitative data that it improved early detection and timely referral. And human resources are very crucial. And here we talk about training, especially supervision from OBGYN, and then adequate number of staff. And these are the important drivers for implementation to be successful. And we also found in our study that nearly half of puskesmas report insufficient number of doctors. And we see from the numbers of days that they are open as well. This is something that still need to be improved. Another two things that we think important is reporting. This is also something we found to be barrier in implementation. And then specialist supervision and system support. So over half of puskesmas benefit from linkage with OBGYN through telemedicine or referral hospital. And it can also strengthen ultrasound competency. So in one of the district that we come, there are WhatsApp group and also consultancy that they can do directly to the OBGYN from primary care physician. So this is very important to improve early detection and also for timely referral. So they can directly consult with the OBGYN related to what they do in the puskesmas. So how we move forward? Based on our finding, we think that we still able to optimize the utilization of this ultrasound in improving maternal and child health. So we see from our previous slide that there are so many modifiable risk factors, and screening is very important. Referral is also very important when you found cases that are high risk. So increasing the number and quality of doctors to perform antenatal care service with their supporting staff, including midwife and also nurses, would be priority that we recommend to be conducted. And then strengthening the monitoring and evaluation, and these include mentoring and supervisions from OBGYN. And then ensuring that the ultrasound is in good condition, so completeness of equipment and infrastructure, including maintenance and funding, is also important. And then lastly, we think that integration of reporting system is very important, including for ultrasound. So we cannot only screen and report, but we need to see from the report what are the problems and what we can do to address the problem. So I'm going to wrap up my presentation with these pictures. This is some of the pictures that we had when we did our study. So as you can see, there are some undeserved population, remote rural area in Indonesia that otherwise they will have very few access for this diagnosis with ultrasound, and now they can have it very close to their area. Thank you very much for your attention and looking forward to the discussion. Thank you.
Thank you very much, Dr. Fitri, for your insightful presentation. Me as a husband, I got a new insight, especially how important ultrasound to visualize my baby. So I can wait for giving you a question in the last session of this session after the fourth speaker and presentation. Okay, Mr. Dr. Fitri. Okay, we move to the we move to the second speaker. Second speaker is Miss Leontine, I think. Leontine Baker. Hello, Miss Leontine.
Hello, good
Hello, Miss
afternoon.
Baker. I can call you Miss Baker or
Please call me Leo. Yes, that's fine.
Leo. Okay, Miss Leo. Okay, Miss Leo. Okay, Miss Leo is gonna representing World Health Organization, which focuses on reproductive, maternal, newborn, child, adolescent health under the World Health Organization Western Pacific Region Office. For your information, I'm a medical laboratory technologist, so I have no knowledge before about the maternal. So that's gonna be my new knowledge about maternal. So she will be sharing her insight presentation in 20 minutes, Mr. Baker. Sorry, Miss Baker. Sorry, Miss Baker, and the time is yours.
Thank you so much, Mr. Sandering. Can I ask the organizers to share my slides, please? And in the meantime, I will start introducing myself. Good afternoon, everyone. My name is Leo Becker. I work as the International Technical Officer at the World Health Organization at the Regional Office for the Western Pacific. And I'm one of the team members for the Maternal, Child, and Newborn Department. And it's actually a great opportunity to be able to speak here. And I would like to thank the Ministry of Health for this opportunity. And also because I'm sure you're aware that Indonesia recently joined the Western Pacific region. So this is also a great opportunity for us, for me and my team, to learn from Indonesia's approaches and from service delivery in Indonesia. So thank you once again. And today I will be presenting mostly about the regional status of maternal child health and the goals that we set for our region, and also how we are planning to reach those goals by 2030. If the organizers are ready to share my slides, that would be wonderful.
Okay. Okay, wait for a minute, Mr. Leo, Miss Leo, Miss Leo.
That's it.
Sorry. I got nervous because that's not my expertise in maternal, so but I have to but I have to introduce you and yeah, maybe this is my first time uh to get the many information about maternal. So
I will talk you through all the steps. Yes.
yeah. Okay, we are waiting for the technical issue in this in this place. Wait
Okay.
for a minute. Miss Leo. Okay, while waiting for the technical issue here, we have a chit chat, have a conversation. Is it your first time to coming to this Indonesia conference?
It is my first time, actually. Yes.
Oh
Yeah.
yeah, in Indonesia.
Yes.
Oh wow! So thank you very much for coming to this your first conference in Indonesia. Thank you. We hope that we can invite you here coming to Indonesia. However, yeah.
Yes. Sure.
We are waiting for you coming to Polytechnic Medan. Actually, we are in Medan, North Sumatra.
Oh, I will be happy to come at some point. Yes, please.
Yeah. Have you ever heard about North Sumatra before?
I have heard of it, yes, but I haven't been. So no.
Yeah. Okay.
So I think
Okay. Okay. This is okay. Before we begin with your presentation, maybe okay. This is your slide. Is it correct?
This is perfect. Yes, thank you so much.
Okay. The time is yours, Leo.
Thank you. Many thanks. Yes. So once again, thank you so much for the invitation to speak here on behalf of the World Health Organization Western Pacific Regional Office. I will refer to my organization as WHO WIPRO, it's a specific title for our region. And yes, so today we'll talk a little bit about maternal and child health in the region and how to integrate it in PHC, in primary healthcare. Next slide, please. Yes, so to start with an overview of the region and the health indicators in our region, it's important to know that in our region, we have 38 countries, and we have both low, middle, and high income countries. And therefore, there's quite a wide range when it comes to these health indicators, but the average of them I will discuss with you now. So we have a maternal mortality ratio in our region of 35 per 100,000 live births, and a neonatal mortality rate of 5.6 per 1,000 live births. When it comes to the under 5 child mortality rate, it is 11.2. And we have a relatively high adolescent birth rate of 16.9 per 1,000 women. When we talk about the coverage of births attended by a skilled health attendant or a skilled health professional, we have a rather wide range. So the average is 98%. However, the highest range is 100% and the lowest is 42% of the births being attended by a skilled birth professional. And then when we look at the family planning practices, we see a percentage of 87.3 of women in the reproductive age that have their need for family planning met by modern contraceptive methods. We're going to dive a little bit deeper into the indicators in the next slide. So if you can move on to the next slide, please. Thank you. Yes, so here you see per country the maternal mortality rate, the neonatal mortality rate, and the skilled birth attendance rate. And for both of the mortality rates, you see a very steep decline. The maternal mortality rate ranges from 18 to 189, with Indonesia being slightly above the average. For neonatal mortality rate, the lowest rate is 3 per 1,000 live births, and the highest is 21. And when it comes to skilled birth attendance, like I already mentioned in the previous slide, we have a rather broad range. Some countries have a coverage rate of 100% and others have 42 or 56. And that depends on which resources or which reference you use. Can we move to the next slide, please? Yes, so this slide shows the world compared to our region for maternal deaths by cause. So what you can see is that the decline in maternal mortality has been steeper in the Western Pacific region when we compare it to the decline on the global level. But you see that if we look at the causes of maternal death, both for the world and the Western Pacific region, they are similar. We have similar or actually the same leading causes of maternal death. And the number one leading cause is postpartum hemorrhage. And then the second one is hypertensive disorders. And then the third leading cause is other maternal disorders. Next slide, please. Yes, so both on the global, regional, national, and subnational, we have set specific targets that are translated into the Global Sustainable Development Goals, and we aim to achieve them by 2030. And the goal for maternal mortality rate is to have a rate below 70 per 100,000. The neonatal mortality rate we hope to reduce to lower than 12 per 1,000. The under 5 mortality rate we aim to decrease to under 25 per 1,000 live births. And the stillbirth rate.
Siapa dia masuk? Tanya aku. Iya.
Someone else is not muted. Sorry, let me just continue with the stillbirth rate, and we aim to decrease that onto lower than 12 per 1,000 total births. And when we focus a bit more on the services that we provide during maternal and child health, we have set more specific targets. And the first target is that we aim that 90% of women receive at least 4 antenatal care visits during their pregnancy. And it's actually wonderful to have this presentation after the presentation of Dr. Fitri, because I learned that Indonesia already, is progressing really well on this in this target. Then the second target is regarding the skilled birth attendant. During the deliveries, we aim that at least 90% of the women give birth attended by a skilled birth provider. And then the third target is regarding the postnatal care and the essential newborn care services. We aim that at least 80% of women and their babies receive adequate postnatal care within 2 days after birth. And then when it comes to emergency care, the goal is that by 2030, at least 80% of districts have sick and small newborn care units, as well as emergency obstetric care accessible to at least half of the population. And next to these 4 very specific targets, we also hope to increase the proportion of women who are able to make their own informed and empowered decisions when it comes to their reproductive health. How are we working on these targets? We can improve these targets, and we can reach these targets by developing policy and plans, by ensuring the right investments, by creating health systems that are resilient and responsive to emergencies. We really need to focus on quality of care, and I will talk more about that in my next slides. We have to ensure adequate health workforce, but also the availability of medication and commodities, devices. So several approaches, or many approaches, to reach these targets. And I will discuss a few of them in the next slides. Can we move on to the next slide? Thank you. So if we want to improve maternal and newborn mortality rates, it is important that we know when do mothers and babies die exactly. And that is presented in this slide. On the left graph, you see that 50% of the mothers, or 50% of the maternal deaths, they occur during the delivery or on the day of the delivery, so the first day postpartum, 50%. So if we want to decrease the maternal mortality rate, we need to target that time frame. When we look to the right graph, we see that the majority of the under 5 mortalities happen in the first week, in the early neonatal period, of which the majority, again, happens during the delivery or on the day of the delivery itself, which again demonstrates we need to focus on that time frame, delivery and just after the delivery. And that is what WHO, Western Pacific Regional Office, is focusing on in the region. We want to improve the quality of care during that time frame, during the intrapartum care frame. Next slide, please. Yes, and I'm very happy that I'm on the same page as Dr. Fitri in her previous presentation, because we really like to strengthen, or really share the message that what we need to focus on is quality of care, as that has become a bigger challenge than access to care across our region. And when we talk about quality of care, it's important that we distinguish different types of care. First of all, we have routine care, routine practices. An example of routine practices is antenatal care, all intrapartum care, also postnatal care. So it's the practices that we deliver to all pregnant women, women in labor, and postnatal women. Then another type of care is the event-based care, and that's the care that we provide after an event occurs. For example, a neonatal resuscitation would be an event, or another example is a postpartum hemorrhage. So we only start providing that type of care after the event occurred. And for, well, quite some years, we've been focusing a lot on this event-based care. We've been strengthening root cause analysis of deaths by strengthening maternal perinatal death surveillance and response, the MPDSR. And we have also been focusing on strengthening the emergency obstetric newborn care as a very specialized management of complications during childbirth. However, what we would now like to focus on is preventing the event from happening in the first place. And how can we do that? By strengthening our routine practices. Many lives can be saved if we would prevent the neonatal resuscitation from happening, and if we would prevent complications such as postpartum hemorrhage from happening. And that's why our focus in the region is on strengthening routine practices during the intrapartum time frame. During my next slides, I will discuss both, for examples for newborns, how can we really improve the routine practices for newborns, and I will also give an example for mothers. Next slide, please. Yes, let's start with the newborns. The majority of newborns, of the newborn deaths or neonatal deaths happen on the day of the delivery or during the delivery. And there is a set of interventions, of very basic interventions, that really increase the survival rate of newborns. And these are 5 of them. We call them the early essential newborn care interventions. And I will discuss them with you. The first one is immediate and thorough drying as soon as the baby is born. The second one is immediate skin-to-skin contact, so that the baby is placed directly skin-to-skin on the mother's chest. The third one is early initiating of breastfeeding, so early initiation within the first hour after birth. Then we have exclusive breastfeeding, so that the baby only receives breastfeeding and no additional formula or alternatives. And these 4 are the case for all babies. And then we have the kangaroo mother care, and that is an intervention that can be applied to low birth rate and premature babies. And kangaroo mother care means that the baby is kept on the mother or father's chest for 20 hours a day. These are all, well, inexpensive interventions. They have a great impact on the neonatal mortality rate, on the infant mortality rate, and overall on the nutrition status of children. And the great thing about these interventions is that they're very inexpensive, and they can be applied in all types of health facilities. They can be applied in, well, rural areas, but also in very remote areas, because these interventions, they don't require high technology or a lot of money. And this makes them applicable for all types of health facilities. Next slide, please. So within our region, we have been partnering with companies to implement early essential newborn care interventions and to really scale up and make sure that this is the standard routine care that all babies should receive shortly after delivery. So WHO and UNICEF together published this action plan for healthy newborn infants in our region. And the goal of this action plan is to eliminate preventable neonatal deaths. And the targets included in this action plan is that at least 80% of the health facilities in our region where births happen, that they implement early essential newborn care as standard practices. At least 90% of the deliveries in sub-national areas, they need to be attended by skilled birth attendants. And through these measures, we aim to decrease the neonatal mortality rate even below 10 per 1,000 live births. And we implemented, or we targeted 9 of our countries in the region, and we chose these 9 countries because these 9 countries are accountable for 95% of the neonatal deaths in our region. And although initially these targets were set for 2020, we recently decided to extend the targets to 2030. Next slide, please. Yes, to help countries implement and really make a routine care to implement early essential newborn care. WHO, the regional office, developed modules to support countries with the implementation. And module 2, for example, provides a 2-day coaching curriculum for the health workforce, so really the service providers. Then module 3 is about, okay, how can we monitor and how can we assess if the early essential newborn care is implemented adequately, and how can we further improve clinical practice. Then the module 4 is about the kangaroo mother care, specifically targeting the preterm and the low birth rate newborns. And module 1 is more of a little bit higher level, is a biennial program review and planning. So it's not really targeting the health providers, but more on a management level. Next slide, please. Thank you. And this slide shows the results of implementing the early essential newborn care in our region. As you can see, over 3 different years, 2015, 17, and 20, you see how the countries where we implemented the early essential newborn care interventions increased with their coverage. And the numbers that you see are the percentage of health facilities that have introduced and implemented early essential newborn care. And 4 of our 9 countries already are above the regional target, and other countries are still working on it. But there's definitely a strong, increase in the use of early essential newborn care. Next slide, please. Yes, and this is a quick overview of, the implementation, just from a different perspective. So in our region, over 6,000 health facilities have introduced early essential newborn care in the health facilities where births are conducted or assisted. And more than 42,000 health professionals have been coached on early essential newborn care and how to implement the interventions that are part of it. 50% of the deliveries have a completed partograph by the end of the delivery. 92% of the babies receive direct skin-to-skin contact immediately after birth. 70% of the newborns in our region, they receive exclusive breastfeeding. And when it comes to the 9 countries where we implemented early essential newborn care, 56% of the babies with a low birth weight or preterm babies received kangaroo mother care. And we've seen a decline after implementing the early essential newborn care of 12 to 56% in neonatal mortality rate in the countries where we implemented this, which really indicates that these are successful interventions. Next slide, please. Yeah, so I would like to talk a little bit more on how these interventions, part of the early essential newborn care initiative, how they really prevent neonatal deaths from happening. So if we look at the first intervention, the immediate and thorough drying directly after birth, what it, for example, does is it stimulates breathing and it also prevents hypothermia. And those both things that it stimulates prevents 10% of intrapartum related deaths and also 10% of preterm death. When we look at the skin-to-skin contact, that prevents 20% of preterm death and 10% of infection deaths. So it also plays a role in prevention of infection. Early breastfeeding within 1 hour after birth also has a very positive impact on newborns and their survival rates, because we know that newborns that were not breastfed within 1 hour after birth, they have 2 times higher risk of dying. And they have a risk of not being exclusively breastfed at all. And then for the low birth weight babies and the preterm babies, there is a very big impact of the kangaroo mother care, because we see a 40% decrease of mortality at discharge and a 44% decrease when it comes to risk of nosocomial infections and sepsis resulting from that. Next slide, please. Yes, and now I would like to focus a little bit on Indonesia-specific data, because neonatal deaths in 2024, there was a total of, well, a bit more than 20,500 neonatal deaths, of which 72% were early newborn mortality deaths, meaning to say that it was in the first week after the delivery, and 28% were late deaths. And if we look at the graph on the right, we see that low birth rate and prematurity, as well as infection, they are leading causes, together with respiratory and cardiovascular disorders, for neonatal death. So if we look at one of the interventions only, let's say we only look at the kangaroo mother care and the impact it has. So if we apply the numbers of the 40% and the 44% impact that we just discussed, if we apply that to the Indonesian rates, that would mean that a total of 4,199 neonatal deaths would be averted by the implementation of kangaroo mother care only. This is a rough estimation, of course, because the numbers come from global evidence, and these are country-specific numbers. But it shows what a great impact the implementation of kangaroo mother care can have, also for Indonesia. Next slide, please. Yes, I would like to give a country example where early essential newborn care really led to improved health indicator for neonatal mortality. And I would like to talk a little bit about Cambodia. Cambodia was challenged by a neonatal mortality rate that lagged behind compared to maternal and under 5 mortality rates. So there was a decline. However, between 2005 and 2010, the neonatal mortality rate stayed unchanged, or kept unchanged, from 28 to 27 per 1,000 live births. And that's when the Ministry of Health from Cambodia partnered with WHO to develop and implement early essential newborn care interventions. Next slide, please. Yes, and here you can see how after 2011, we implemented early essential newborn care. And here you can see how the implementation of the interventions really increased. Over time, there has been a bit of a decrease, which is a trend that we see often when we implement new interventions. But now again, there is an increase in 2022. And if we move on to the next slide, the impact of that is visible, because the blue line represents the neonatal mortality. And you see that up to 2010 or 11, the line is, well, not horizontal, but slightly more horizontal. And after that, the line becomes steeper. And that was directly after implementing early essential newborn care interventions. So it shows the impact of the interventions on the mortality rate. Next slide, please. So that was a little bit about the interventions when it comes to neonatal mortality and how we can address that. And yes, what I like to focus on is that it's inexpensive, very easy to implement interventions that have a great impact and are applicable for all primary healthcare facilities, but also secondary and tertiary facilities. Now I would like to focus a little bit on the maternal side of improving quality of care. Well, like we saw in one of the previous slides, we want to focus on the intrapartum care and strengthening the quality of that, because that's when most 50% of the maternal deaths occur in our region. So we are currently partnering with countries to do facility-based quality of intrapartum care assessments. And the objective of this is that we, in selected facilities, we review the current intrapartum care, the current practices, we identify areas for improvement through root cause analysis, and we develop an improvement plan. We provide clinical coaching, and we establish a continuous improvement cycle to implement and sustain the improvements that we identified in the improvement plan. And it's a very comprehensive assessment. We are focusing on the implementation of recommended medical interventions, but also the service that are provided by the health facility. We focus on the infrastructure and the environmental hygiene, but also on the availability of medicines and supplies, if there are policies and guidelines, and how the implementation of it is. And we also look at the facility-specific health indicators. And so this is a one-time assessment with a continuous follow-up, because the health facility keeps reporting on the set targets of the improvement plan on a quarterly basis. Next slide, please. Yes, and then another tool that can be used to improve the quality of intrapartum care, both for mothers and for babies, is the use of the labor care guide. And I think many of you heard of it. It is replacing the previous partograph that we used to monitor fetal and maternal well-being. And all the latest evidence is included in this labor care guide. And what really is the added value compared to the previous partograph is that we try to, or it is aiming to prevent unnecessary medical interventions. So one of the things that it includes is that we are letting go of the expectation that the dilation during labor needs to progress 1 centimeter per hour, because evidence has shown that that's outdated information. And we only define the active phase starting at 5 centimeters instead of earlier, which was the case in the partograph. Next slide, please. So
Miss Leo, you only have 5 minutes left.
Perfect. Yes, I have 2 more slides, so I will manage. Thank you. So we discussed specific interventions targeting the quality of care for mothers and newborns during the intrapartum care. And now I would like to focus a little bit on the system level, and I would like to discuss how quality of care improvements need to be integrated into the entire primary health care. Next slide, please. Yes, I would like to give one example from Laos, and I'll keep it short. But what we did in Laos quite some years back is that we visited a health facility and we collected data on the current practices. So we did chart reviews, we did patient interviews, and we did observations in the clinic. And one of the findings that we found was that only 2 out of 10 women reported that their blood was being checked as part of the antenatal care. 8 of the women, of the 10 women, never had their blood tested. And then when we discussed this one level up with the facility management, they were surprised and they asked the health workers, mostly the midwives, why aren't you taking the blood during the antenatal care? Because that was one of the recommendations. And then the reply was, we want to, but it's not allowed as per the scope of practice. So then it was taken to a higher level, to a provincial level, where we really started to assess, okay, what is in the scope of practice and how does it align with the legal framework? And we noticed that a lot of things in the scope of practice are not aligned with the legal framework. So then we took it to the national level and we had to change policies and regulations and really had to redefine the scope of practice for the midwives. So this illustrates the necessity for all levels of primary healthcare to be included when it comes to quality of care improvement. Next slide, please. Yeah, so this is a very big slide with a lot of information, but due to time limitations, I will keep it short. This shows the responsibilities of all levels within primary healthcare when it comes to quality improvement and how important it is for all levels to be integrated into this. We start at the community level, but then the health workforce, they are there for technical support. Then department and units, they are there to set targets when it comes to quality and monitoring and planning. The hospital governance plays a role in leadership and culture and supporting the health workforce. The provincial district health department, they need to take care of referral systems, for example, but also medical supply, human resource allocation. And then on the national level, completely on the left, there's of course the Ministry of Health, and it's their role to, well, decide the policies, regulation, licensing, but also accreditation of the health workforce. So each level has a role to play when it comes to quality of care improvement. Next slide, please. So I have come to the end of my presentation. I think the key messages that I wanted to share with you today is that our approach, or our recommended approach, to reduce maternal and newborn mortality in our region is to strengthen the quality of routine care, both for mothers and for babies. For the integration of quality improvement mechanisms, it is essential that all levels of primary healthcare are involved, and some of the interventions I discussed with you today that can help improve the quality, and they include early essential newborn care, intrapartum care assessment for mothers, but also newborns, and the labor care guide. And these are all interventions that don't require a lot of money. They don't require high technology, but they have very great impacts. Next slide, please. Very much actually for your attention, and thank you again for inviting me to this conference. And I'd be happy to answer any questions at the end. Thank you.
Thank you so much, Miss Leo, for your meaningful and inspiring presentation. Again, your presentation opened my eyes how important my wife to take a part of my life, my son life. Okay. Okay, maybe we're gonna open the discussion and Q&A session for the last two speakers. We have around 15 minutes for questions and comments or reflection from the audience, not from me, because yeah, of course I I have a question, but it's general, not a technical matter now. So for the audience, you may type your question and type and in the chat box or raise your hand to speak directly, and I will read the question to our speaker. If you guys have a question, we invite Dr. Fitri also. Please add spotlight. Okay. I'll remind the audience that this is the discussion and Q&A session. The audience, so if you have a question, comments, or reflection from the audience, you may open your mic and maybe you can speak directly in this Zoom. Or you can type your question in the chat box. Okay, maybe to begin our session, our Q&A session, let me begin with my question. Of course, this question is general, not a technical matter now, because yeah, I'm from a medical laboratory technology. I see that from the first speaker that if a patient, yes, from the first speaker, I got the information, and I consider that if a patient comes to the community health center like a puskesmas for ultrasound, would a doctor or a midwife who has been trained in ultrasound to be sufficiently qualified to explain or analyze the available data? And regarding to the authorization to use ultrasound, would there be any difference if it is performed by OBGYN and general practitioner like Medan, or even general doctor? What is your perspective on that matter to Ibu Fitri?
Okay, thank you very much for the question. It is pretty new for us because it's launched in 2022. So I'm sure we are all still learning from this. But for the competency for ultrasound, in primary care for now is actually for doctors, and the competency for physician, general physician or general primary care doctor is different from OBGYN. So for general doctors, the ultrasound that the competency for ultrasound uh, is focusing on the basic ultrasound competency. So they have like 12 competency. So identifying, for example, abnormality of the baby position, abnormality of the placenta position, and also whether it's a twin pregnancy. So those things are the things that can be diagnosed and identified by physician in the primary care. But for other cases, including for the gender or the sex of the baby, is something that is beyond the competency of the general physician in the primary care. So this is something that the OBGYN needs to do. So it is very different. Another thing that are different is the ultrasound that is now in primary care is the 2-dimension ultrasound. So it is also different from the 3-dimension ultrasound that generally available at the hospital. The point is that we try to improve access, trying to make it closer, not to diagnose and then treat at primary care, but to be able to screen early and then trying to refer early as well for timely referral. So that's, I hope that answer your question. Thank you.
Thank you, Dr. Fitri. My second question, if the government give us and then the number of ultrasound has completed in every community health center, puskesmas, can you predict if the ultrasound is exists in every puskesmas and also train a doctor or midwives? Is there any data or we can do a prediction that it can decrease the number of this case? Yeah.
Okay, thank you. This is also a very good question. So, based on the several references, actually, more mortalities caused by ultrasound can be caused by mortalities causes that can be reduced by ultrasound is about 6%. So we still have over 90% that can be caused by preeclampsia and by comorbidities and other diseases as well. But what we need to think about is not those 6% of mortality uh, in maternal period, but also whether it can reduce near miss cases and whether it can reduce morbidity in mothers, and also some other cases for infants. So, for example, IUGR or intrauterine growth retardation that can be detected by having or diagnosing with ultrasound and can be referred early and then also be treated early. So, those are the things that we need to also think about in addition to the benefit of having ultrasound to reduce maternal mortality. Thank you.
Thank you, Dr. Fitri. So I got a new insight from you, yeah, from your perspective. Now we go to the audience questions. Now we have Ma'am Hannah, Miss Hannah. Can you add a spotlight for Miss Hannah? Hello, Miss Hannah.
Hello, Mr. February.
Miss Hannah will deliver her question to Miss Leo, right?
Board of the speakers.
Board of the speaker. Okay.
Yeah. Thank you, Pak Febri, for the opportunity given to me. I want to ask question to Bu Fitri and also Miss Leo from WHO. My question for Bu Fitri, following the launch of integrated primary healthcare in 2021, what are the primary challenges and implementation effectiveness indicators for achieving the new standard of INC, especially concerning the mandatory minimum of 6 visits, and also the provision of doctor-led USG screening and the integration of mental health screening at the primary health facility level. That's my question for Bu Fitri. And my question to Miss Leo. Yeah, my question for Miss Leo, based on the claim that you have already explained to us in this afternoon, that kangaroo mother care prevents 40% of MMR at discharge and 45 of the risk of nosocomial infection or sepsis. My question is, what are the primary psychological mechanism and key elements of kangaroo mother care that specifically account for the significant reduction of 40% in mortality discharge and 44% in the risk of nosocomial infections in low birth weight infants? That's my question for Miss Leo. Thank you.
Thank you, Miss Hannah. Maybe we can start from Miss Leo. Time is yours.
Yes, thank you so much for the question. That's actually a very, very good question. So what evidence has shown that what KMC, Kangaroo Mother Care, does exactly for the baby? And what we know is that, first of all, it regulates the nervous system of newborns. It prevents hypothermia, and especially newborn or premature newborns, they struggle a lot with their temperature regulation. And hypothermia is also linked to infection, of course. So that also reduces the risk of infections. So it has different physiological effects on the baby. And on top of that, research has shown that that's a bit of a long-term effect, but the neurodevelopment of babies that have had KMC, that also progresses better than newborns or preterm newborns that didn't have KMC. So there are several aspects, both on the neurological part, on the nervous system as well, but both also temperature and infection rates. So that's what it does. It is a little bit difficult to really define what's happening exactly because it's difficult to research. So there might be more benefits even, but these are the benefits that we know, and those impacts contribute to the decreased risk of neonatal death. Yes, thank you.
Thank you, Ms. Liu, for the answer.
Okay, continue to Dr. Fitri.
Okay, thank you very much for the questions. So I will start with your first part of the question regarding the primary indicator first. For antenatal care, we have the first visit, and this is first visit during first trimester. Not only first visit during the pregnancy as we have before, or K1 murni and K1 access. And also we have the K5, which is also need to be a visit that conducted with the doctors, and then 6 visits. So the whole 6 visit for the pregnancy, and then also the components of antenatal care. So the 12 components that right now included in antenatal care, those are the primary indicators that we need to fulfill and also track and monitor in the context of integrated primary care. But the primary challenges, and this is already 2025, but when we have several studies actually looking at how the puskesmas implement and the rollout of IPC, and it seems that first thing is the technical guidelines for how to implement IPC at the puskesmas level, and then how to monitor and supervise as well. Those are the things or the regulation that needs to be already developed but need to be socialized and make into a more specific technical guidelines for Puskesmas. And then the readiness of Puskesmas, because now we see a lot of different programs, and most of these program is in the hand of the Puskesmas. So if you see the free health checkup right now is the standard for Puskesmas as well. And now with the cases, some cases of the free food for lunch, the lunch program, when we see some cases, it's also become the responsibility of Puskesmas, so monitoring and supervisions. So we see the readiness resources of Puskesmas is still something that become the main challenges because they already have so many activities in their routine program, and then there are additional program that they also needs to monitor and supervise as well. So if there are some Puskesmas practitioner here, kudos to all of you, semangat. And then another thing which is important is actually also highlighted in the presentation is the numbers of staff itself and how this is not only the number but also the quality and how the staff, especially the doctors, can work together with the internal staff at the Puskesmas and also their network. So the OBGYN, the DHO, and within the Puskesmas with the midwife, the nurse, and also the other supporting staff at the Puskesmas. But beyond Puskesmas and beyond the provider, there are also important barrier that we see in our study is access to first trimester antenatal care visit. So our first trimester visit for antenatal care is still relatively low. So, and we know that if we cannot have that first visit in the first trimester, then we lose a lot of things that we can otherwise diagnose and identify in the first trimester. So that is something that can not only be addressed by the Puskesmas or by the healthcare force. I believe that this is something which needs multiple stakeholder involvement to be able to address, because how to transfer pregnant women from remote area, for example, when they're still having motion sickness, morning sickness, and then they need to go to Puskesmas in some rural area. We talk about 2 to 3 hours or even more, and not with the very smooth highway as we have in Java or in Sumatra, but it's with the very, for example, in one area that I visited, they need to go, if they go by motorcycle, they need to go through 12 little bridges. It's very small path. But if they want to go faster, they need to get into small boat. And I went into that boat, and it's not a pleasant experience for me. So I can imagine it's not a pleasant experience for pregnant women as well. So getting those pregnant women to come to their first antenatal care visit during the first trimester, I think is one of the main challenges. Thank you.
Thank you for the answer. I think there's a real big challenges for us. That's a real fact in Indonesia, I think. Thank you for the answer.
Thank you, Miss Hannah, for your questions. Thank you, Miss Liu and Dr. Fitri. Then we're gonna wait for another question in the chat box or directly from audience. Is that enough? Okay, I consider that all the audience have been clear with all the information delivered by our both speaker. So thank you for you both speaker who give us many insightful related to each topic of yours. Thank you very much. And then we truly appreciate our distinguished speaker for their valuable presentation and meaningful discussion today. Your contribution have provided us with a new perspective, inspiration, and in advancing health research and practices. If you don't mind, we can also do a collaboration with Polytechnic Medan, between Polytechnic Medan or UNS and WHO with Miss Leo or do a collaboration related to the research or something like conference like this. So thank you. Okay, to end this session, maybe we can give Miss Leo and Dr. Fitri to conclude their presentation. Maybe we can start with Dr. Fitri. Time is yours.
Okay, thank you very much for your opening, also for summarizing the discussion today. I think what we learned from what I present and also from what Dr. Leo present is that we still have important things and important problems to address in terms of maternal and child health. But this is something that we cannot do by ourselves within the health divisions, but something that needs collaborative effort with others. And it is important to actually try to make it awareness, like when you mentioned, Pak Febri, that as a husband, it is also very important to be involved and also as a family, because we know that the problem of mothers is not only related to the health but also social, psychological, and this is something that needs to be addressed not only by ourselves in the health department but also in other area as well. And social economics and regions, as we present before, is also something important, and this is also something that we cannot address by ourselves. So collaborative efforts is very important to address this. Thank you.
Thank you, Dr. Fitri. And then we go to the conclusion to Miss Leo.
Thank you so much. Yes, also for the invitation to speak during this conference. I think it was very helpful for our regional office as well to learn from Indonesia. And one of the things that I think Indonesia is very strong in, or that's very strong program in Indonesia, is your midwifery program. I am a midwife myself by background, and within our region, the Western Pacific region, I think many countries can learn from the midwifery program that Indonesia has set up. And I'm aware that recently you also implemented a leadership program for midwives. So I think our region can learn a lot from how you are strengthening your workforce. That's one aspect of quality of care, strengthening your workforce. And then, of course, I think we have to look into other aspects of how we can further strengthen the quality of care. I think Indonesia is showing great progress, and we have very promising results until now. And yes, I'm very confident that the progress will develop in a good direction. So I'm very happy to see that. Regarding quality of care, we have to focus on different aspects. During my presentation, I focused on intrapartum care, but I'm very happy that Dr. Fitri highlighted ANC, the antenatal care, and also the impact of ultrasounds and the need for ultrasounds. And from WHO perspectives, we are very happy to support our countries. We are very happy to support Indonesia if that is desired by Indonesia. So yes, we are also really looking forward to a collaboration. Thank you so much.
Yes, if any opportunity we can collaborate between Polytechnic Medan, WHO, and UNS to do maybe research or something like this conference to maybe give more information to husband like me. Okay. Thank you so much for your insightful and thoughtful conclusion, both speaker, Ms. Leo and Ibu Dr. Fitri. Thank you so much. Have a good day. If you don't mind, you can still connect it with us in this conference after, until the third session end. And then thank you so much. Okay, let's give a warm round applause to all speakers. Yeah, thank you again, and yeah, thank you for your emoticon. Okay, for the third session of this conference will conducted by the board speaker from Indonesia, from Polytechnic Medan, will be delivered by Miss Masrah, Ibu Masrah, and Bapak Haripin Togap, right? Okay, can you add the spotlight for both speakers, for next speakers? Halo Ibu Masra, halo Pak Haripin. Okay, Pak Haripin is here. And then Ibu Masrah. Masrah, Ibu Masrah.
Okay, good afternoon.
Good afternoon, Mr. Haripin. We'll wait for Ibu Masrah join with us here. Okay, okay, Bu Masrah here, and then
Good afternoon,
in
Mr.
this third session, it's gonna be started by Ibu Masrah from Indonesia. She will be delivering a presentation entitled. Can you share the CV first, or continue to the cover of the slide presentation? Okay, CV ya, CV. Okay, Ibu Masrah. Professional summary. She is an experienced lecturer in the occupational health and safety with a strong interest in research, scientific publication, community service, committed to developing knowledge and guiding students to achieve high levels of competitiveness at both national and international levels. She has graduated from Magister of Public Health, Universitas Sumatera Utara, University of North Sumatra, and then for the bachelor's degree English education from UMN, right? Okay, and then diploma 3 in the chemistry education from IKIP Bandung. And she also have a professional experience and reputable publication in many journals. So without further ado, I invite Miss Masrah. Halo Ibu Masrah.
Hello. Good afternoon, Mr. Febby.
Can we go to the cover of the presentation? First slide.
Okay.
Committee, please. Ibu Masrah, how are you today?
I'm fine, Mr. Febri sendiri.
Thank you for joining us in this conference, Ibu Masrah.
Okay, you are welcome.
Ibu Masrah will deliver the presentation entitled Development of Maternal and Child Health MCH Services in the Integration of Primary Service in the Pharmaceutical Sector. And then the 20 minutes is yours, Ibu Masrah.
Okay, thank you for Mr. Febri sendiri. When we care for mothers and children, we care for the future. Assalamualaikum warahmatullahi taala wabarakatuh. My Honorable
Waalaikumsalam.
Director and Deputy Director of Polytechnic Kemenkes Medan, my Honorable Head of the Center of Development and Education of Polytechnic Kemenkes Medan, and all my beloved audiences. My name is Masrah, and today I'm going to talk about development of maternal and child health services through the integration of primary care in pharmacy. This topic is remind us to that healthcare is not only about treating disease, it's about building strong foundation for life starting from the earliest stage of it. Maternal and child health is primary focus of the primary care system at community health centers. Many pregnant and breastfeeding mothers still use medication or cosmetics without considering their safety. Pharmacists not only manage medication, but also provide pharmaceutical care through counseling, education, and monitoring for side effects. The goal is to ensure the safe, rational, and effective use of medication and health products for mothers and children. Next.
The goal of development maternal and child health services in the integration of primary service in the pharmaceutical sector. First, explain to the role and contribution of pharmacists in maternal and child health services at community health centers. Second, identify forms of pharmaceutical care that support patient safety. Third, emphasize the importance of selecting safe medication and cosmetic during pregnancy and lactation. Fourth, raise public awareness of the dangers of risky products. Next, maternal and child health is a key pillar of health development to reduce maternal and infant mortality rates. Community health centers or puskesmas as primary care centers carry out promotive, preventive, curative, and rehabilitative function. Pharmacy care professional services to ensure the rational and safe use of medication for patients. Pharmacists play a role in monitoring the use of medication and cosmetic to ensure they do not harm fetuses and infants. Next, toxic drug and penetrates the placenta and breast milk. Some medication can cross the placenta or enter breast milk, posing a risk to the fetus and infant. Example, isotretinoin, tretinoin, acitresin, tetracycline, warfarin, captopril, enalapril, streptomycin, kanamycin, chloramphenicol, lithium, phenobarbital, valproate, and pentoin. Therefore, pharmacists must assess the safety of medication before use by pregnant and breastfeeding women. Next, the role of the pharmacist. First, drug provider and manager. Ensure the availability of essential drugs like iron, folic acid, vitamin, and vaccines. Manage medication according to good storage practice and good distribution practice principle to maintain quality. Second, pharmaceutical care provider provides counseling on the usage and side effects of medication. Explain safe cosmetic during pregnancy and breastfeeding. Collaborates with doctors, midwives in selecting appropriate therapies. Next. Third, therapy and pharmacovigilance supervisor. Monitor drug side effects, especially in vulnerable groups like mothers and children. Improve patient adherence to treatment through education. Report side effect or therapy discrepancies. Fourth, health educator and promoter. Provides education on safe drugs and cosmetics for pregnant breastfeeding women. Actively participate in integrated health was or posyandu or pregnancy classes to improve healthy literacy. Encourage preventative behaviors through nutrition and immunization education. Next. Compile a list of pharmaceutical activities supporting maternal and child health. Compile The first, compile a list of recommended medication and health products for mothers and children. Second, conduct individual and group counseling or drug therapy and the dangers of risky product for mothers and children. Third, monitor the use of maternal and child health or KIA medication in the community health center or puskesmas work area. Fourth, report pharmaceutical activities to the head office. Fifth, collaborate with the health team on immunization and nutrition program for toddlers. Next, impact and benefit of the role of pharmacists. The first, improving material and child safety by preventing the toxic effect of drugs and cosmetics. Second, promoting rational, effective, and efficient drug use in mothers and children. Third, improving adherence to therapy for pregnant women and children. Fourth, strengthening reporting of adverse events, pharmacovigilance. Fifth, raising public awareness of the importance of the safe drugs and cosmetics, especially for mothers and children. Next. As a conclusion, pharmacists play a strategic role in maternal and child health services at community health center or puskesmas. Second, they not only manage medication, but also provide education, monitoring, and interprofessional collaboration. Third, through pharmaceutical care, pharmacists help ensure safe, high-quality maternal and child-centered maternal and child health services. I think is enough. Okay, Mr. Febri. I think it's enough. Back to Mr. Febri.
No sounds. Febri. Sounds. Suara.
Graduated in the University of Queensland, Australia, and Mahidol University, Bangkok, Thailand. Okay, and then he also have many publication in reputable journal, and also research related to their field, his field in his research. Okay, we're gonna start it off his presentation. Can committee present or?
Okay, let me share.
Okay,
Let
Pak
me
Haripin Togap will directly share the presentation. Okay, Pak Haripin, the 20 minutes is yours now.
Okay, thank you, Mr. Febri. Good afternoon. For my colleagues, especially for the committee and the respects the speakers and all participants that joining from several areas, especially from Polytechnic Medan. Let me introduce myself, Haripin Togap Sinaga, and more detail have been presenting by Febri. And it is a great pleasure for me to be a speaker in this conference that conducted by Polytechnic of Medan, that bringing the topic development of maternal and child health services in primary health care. Today I'll be talking about breastfeeding for a better future. I think this is related to the topic. And the topic is close to my vision, actually. And we'll explore how breastfeeding is more than just a feeding practice, but it is an investment in human capital and public health interventions and a global commitment to achieve the healthier next generations. Okay. Seem most of you have seen many times this picture, this graphic, or this slide before. But this afternoon, we are not talking about the anatomical structure of breast, but this is just to fresher that the feeding practice or the process of breastfeeding is started from, we can see, from the mammary gland produce milk through ducts and transferred to the nipple. And this process triggered by hormone prolactin, sorry. Okay, hormone prolactin and also to hormone. So these circulations, we call it the breastfeeding, a beautiful and biological designs. But the important things that we should present this afternoon with your study is these three dimensions. The first is evidence, policy, and actions. In the evidence, we want to understand why breastfeeding matters and what science tells us about the impact of the breastfeeding. And the evidence should bring to policy. In policy, we should identify how government and institutions enable and hinder the optimal breastfeeding practice. And policy without action is useless. So in actions, we highlight what can be done on the ground and what Polytechnics have done in the ground. These three elements are like a cycle. evidence inform policy, policy guides action, and actions generate the new evidence. Okay, let's start with the first questions. Why breastfeeding matters? Because it is one of the smartest investment that any nation can make. It is not only saves lives, but also contribute to a stronger and more productivity society. Breastfeeding is a vital part of providing first vaccine, best sources of nutrition, and bolsters the brain development. The other matter is breastfeeding nurtures national economy and improve country's prosperity. But even though we know this evidence, this is usually paradoxical because it is always underestimated in public and policy discussions. Let's see the global evidence. The global evidence for mothers, especially for infants, diarrhea and pneumonia is the two leading cause infections diseases that causes mortality in the world. But by breastfeeding, it can be reduced. And intelligent questions increase by 2 to 3 points. And the global evidence also recorded that by breastfeeding, it prevents over 820,000 child deaths annually. And for mothers, it lowers the risk of breast and ovarian cancer, reduces type 2 diabetes and postpartum depressions, and it prevents 20,000 mothers' death from the breast cancer. For society, by breastfeeding, it saves healthcare costs and boosts the productivity and leads to a smarter, healthier generations and improve economic growth. So Indonesia is trying to find the optimal health in the 2045. So this is the time we learn how evidence, policy, and action can be taken for the next. Okay. We know that the coverage of exclusive breastfeeding is still in average. Means that more than 50% mothers do not give breastfeeding for her children. So what is the cause of these actions? According to global breastfeeding research, the cost of not breastfeeding, it reached about 302 billion annually. Or if we put it in rate rupiah, it is about 5,000 trillion rupiah. This is because of suboptimal breastfeeding. The key drivers of this is the first is the increased healthcare costs due to the preventable disease. So the government spend much money for the healthcare because of not breastfeeding. And the lower cognitive potential and lost productivity, inequities in child development and maternal health. But the research also found that if we investing in breastfeeding for $1, it will be returned a 35-fold in economic and human capital gains. And you can find it in Walters and Rollins. So So we go to the global and regional progress. AVF rate stands at 48%. This is in 2023, 48,000. But the global target, it hopefully 70% by 2030. Asia and Africa saw the significant improvement in the past decade. And Indonesia, we have the strongest improve with a 5 to 10 percentage point increase since 2017 to 2023. So we should record that normally the improvement is should about 2.5% every year for exclusive breastfeeding. However, Southeast Asia still face challenges. More of them give partial breastfeedings, and particularly in Thailand and Vietnam. And Indonesia, now we can see this chart. Actually, this chart is produced in 2013, but what I want to say from this chart, we can see that Indonesia, yeah, we got about 40%, and Thailand, Laos about 25, Myanmar about 22, and Thailand about 15. But in fact, the prevalence of stunting in Thailand much lower than Indonesia, even though the AVF is higher compared to Thailand. We can see stunting in 2023, Thailand 11%, Indonesia about 21 and to 22%. The explanations we can discuss later. Okay. This is another chart that you want to see. Okay. This is the percent of babies breastfed within an hour of birth, early initiations breastfeedings, and percent of babies under 6 months. This is the current percentage, this is 20 and 23, and the global target for 20 and 30, we can find here for the exclusive breastfeedings, we still have to reach about 22% for about 5 years. The questions, can we got it? I mean, the global can do it because as I said before that normally is it about 2.5% annually, the improvement. And for the percent of children breastfed at 2 years is lowest, is about 45%, and the target is only 60% in 20 and 30. So let's see the visuals. This map to clarify us where is the position of Indonesia. Okay. Okay. Asia and Africa saw the biggest improvement here. And some region face decline due to the conflict. It's mostly about in several North America and this is in Europe. So Indonesia is among the strongest improvement with 5 to 10%. Okay, after we have the evidence, I say the evidence should go to the policy. Now we find the enablers first. Baby-friendly hospital. This is one of the enablers to reach the global target. And paid maternity leave, work place lactation support and enforcement of International Code of Marketing of BMS, breast milk substitute. Next, we can see how Indonesia have the enablers. And the barriers is the aggressive formula marketing. From the previous speakers, I heard that it is still the most barriers in achieving the breastfeeding target, the aggressive formula marketing. Inadequate maternity protections, weak health system capacity, and social cultures. Indonesia have produced several policy to support the breastfeeding. We can see the law number 36 in 2009. The governments produced this to ensure every infant have right to exclusive breastfeeding and requires health facilities to support breastfeeding practices. Means that every mother have the right to have exclusive breastfeeding. And following the government regulations number 33, 2012, this is to define the responsibilities of government, health facilities, and health workers in supporting exclusive breastfeeding, etc. We have about 6, 1, 2, 3, 5, 6. But the problem for Indonesian is the quality of the implementations of the regulations in the field or in the ground. This is one of my study. I use the health belief model to find what is the barrier in Medan city. What I found is quietly similar in other countries or in other areas. The problem is the barrier because of returning to work early, even though the government have reminded that the work women should have time to breastfeed her child, but still because they need money. So it is the problem for Indonesian, especially in the city area. And limited support from husband and family, and exposure to formula marketing, and low maternal self-efficacy are major areas, major barriers. So we're stretching with the exposure to formula marketing.
Excuse me, Mr. Haripin.
5
Maybe
minutes.
we have a technical issue on your slide because your slide still freezing in current breastfeeding rates in the Southeast Asia. Is that true that you do a slideshow for current breastfeeding rates data?
No, not exploring barriers. Sorry. I stop first, yeah?
Okay.
Okay, let me. My voice is okay? Okay. This is the current slide. Is it?
Okay. Okay, now it is visible, Mr. Haripin.
Okay. One of my study exploring the barriers to exclusive breastfeeding in Medan City found that the barrier what we found is quite similar to other countries. The first barrier is because of the returning to work earlier. So the problem is in Medan City, the early initiation breastfeeding numbers or prevalence is lower than exclusive breastfeedings. But in my presentation, I want to present the barriers of the exclusive breastfeeding. The first is returning to work earlier and limited support from husband and family, and exposure to formula marketing and low maternal self-efficacy are major barriers. So we focus at exposure to formula marketing. Mostly now, the clinic and the hospital, especially private hospital, mostly they promote the formula to mothers before leaving the hospital. These barriers are not unique to Indonesia, yeah, because they reflect a broader pattern across many urban and also in many countries. So we go to the effective strategies interventions. So the first, we should reinforcing lactation counseling at the primary care level. I know now the government or Minister of Health are now doing the training of the counselor, yeah, lactation counselors in many areas, especially in North Sumatra, and enforce the international code, empowering families and workplaces, paid maternity leave, baby-friendly hospital, peer counseling, and family support. And maybe I want to share my experience when I work under the government, under the UN, United States, United Nations in UNICEF, Banda Aceh at the time, when my wife pregnant and then most to give birth, I have paternity leave about 3 months. But if it is for the women workers, they have 6 months maternity leave. And the strategy, another strategy is baby-friendly hospital, peer counseling, and family support. And the new one is digital tools. How can use online lactation mothers group and telemedicines and national campaign and advocacy. So, what we have in Indonesia, in Medan, and now it includes to the global challenge. So aggressive formula marketing is the biggest barriers in the world in promoting breastfeeding. Takes about $55 billion, yeah, to produce. Walters calculate this, and this is improved since 2008. It improved significantly up to now. And the culture, it's cholesterol myths and stigma. Maybe in several areas still have this cholesterol myths about the cholesterol. Someone said it's dirty, it's not good for the babies. And limited support, maternity leave, workplace. But as I understand, Indonesia has adopted the maternity leave for 6 months for the women workers, especially for the government workers. And the weak health system and economic pressure, especially in rural areas, urban and rural areas. Now we go to the global action agendas. We first need to strengthen and enforce policies, regulation, and standard. As I presented before, we have 6 regulations that have been produced by government Indonesia, but the problem is the quality of the implementation of the regulations. And the next, how we think that we invest in baby-friendly health system, yeah, to support for mothers. And then we empower families and communities, leverage digital innovations, and align breastfeeding with SDGs. SDGs number 3 to 5 is related to breastfeeding. So call to actions from evidence to policy. I think these 5 have been presented before, but the important thing is what is the role of Polytechnic, especially lectures or academia, in advancing breastfeeding policies. So for my friends, for my colleagues, I think it is important session for us. How can we take the actions to get the breastfeeding optimal in Indonesia, especially in North Sumatra? First, we're generating evidence by conducting applied and community-based research on breastfeeding practices, determinants, and barriers. I think this is midwifery and nutrition and nurse department is related for them. And next, implementing mixed method cohort and ethnographic studies to explore mothers' experience and digitals. I put it in red bold because I just do the ethnographic studies. It is interesting studies also for us if you want to study qualitative study with ethnographic studies approach. Evaluating the effectiveness of health promotion interventions and producing local data that inform both regional and national. The five, producing local data is the most important thing. Yeah, if we can do that, I think it is very important to show the government that we have the real data. Because if we ask the health workers in Puskesmas, mostly they tend to answer or to say the good thing for us about the prevalence of exclusive breastfeeding. This is my experience. If I ask the nutrition workers, they said that they can cover about 70% ABF, but in fact, not more than 30%. So we should take the advantage of these situations. And then translating evidence into policy. Okay, most of us has studied how to make a brief policy. So this is the time to translating evidence into policy and driving actions and implementations, like designing, evaluating training modules for health workers and students, supporting community-based breastfeeding education and peer support networks, integrating breastfeeding topics into curricula for public health midwifery and nutrition students. So this is one of my study, ethnography study. I use the platform of TikTok and Instagram and Facebook, and to find what is the communication of young mothers, talking about the breastfeeding, they sharing the experience, and then we combine, we use the tools to analyze the study, and then the result, we have the 5 main themes that the young mothers always talking about emotional support, breastfeeding challenge, and family influence and adaptation strategies and product reference. This is the most theme that usually young mothers, children mothers share the experience with other mothers in the platform of TikTok and Instagram. Hopefully my time is still okay. So this is the last slide. The conclusion or the key message that we should bring after this conference first is breastfeeding is a global investment. We should think this is a global. Yeah, we should think how to produce a healthier and save money for the next generations. And the policies and collective actions, this is essential. We should run the sick regulation properly in the ground. Policy mean little without enforcement. So enforcement is important to run the policies. And action needs support system. Yeah, like for example, in Polytechnic, we should have like lactation room, breastfeeding room. So we need support system to provide the room. And we should, in action, we need digital innovations and the collaborations among all sectors, including academia. Okay, so if you want to read more about this material, you can find in my book, Breastfeeding for a Better Future, Evidence, Policy, and Action, written in Bahasa and English. Thank you. I give to moderator Febri. Time is yours now.
Thank you, Mr. Haripin, for your insightful presentation. I do agree with you, Mr. Haripin. Poltekkes have a good opportunity to take a part of this issue, breastfeeding, right? And also make the Polytechnic Medan trusted by people and differentiated with from our other
Right.
institutions like Unimed, USU.
Yeah.
That makes us very different with other.
It's time for us to do that.
Yes, we can start with you. Maybe you can take action in the Gizi department.
I
Okay,
hope so.
thank you.
Yeah.
Thank you, Mr. Haripin. And then we go to the next, the last session of this conference is Q&A session. Maybe for the audience, if you have a question, you can directly raise your hand. Now we have Sri Wahyuni Tanjung and then Bapak Johnson, and also, is there any more? Yeah, Ibu Anggi, and then maybe if you cannot directly deliver your question, maybe you can
You
type
can use bahasa
in the chat
also.
box. In the chat box, sorry. Okay, for the first question, we can go to the Ibu Sri Wahyuni Tanjung and then Pak Johnson. Halo Ibu Sri Wahyuni. Halo.
Good afternoon, sir.
Good afternoon.
Yes. Good afternoon, everyone. Thank you for the opportunity to give me to ask a question. So I want to ask a question regarding Mr. Mastra presentation. Mr. Mastra presentation, sir. My question is, why is collaboration between healthcare professionals so important for maternal and child health?
Okay, is that enough, Ibu Sri?
Yes, enough. Thank you for
Okay,
explanation.
thank you. Before the answer is delivered by Ibu Masra, we can go to the next question from Bapak Johnson.
Okay, thank you for the time, Mr. Febri. Yes, what a good or interesting presentation of the two speaker.
Thank you.
Yeah, and I want to talk to ask to Mr. Haripin Sinaga.
Mr.
In
Siva.
your chart, title current breastfeeding rates in Southeast Asia in percent. Yeah, I see that exclusive breastfeeding Indonesia is bigger than Thailand in rate, even up to 6 months and continued breastfeeding up to 2 years. My question is, why do the stunting rate in Indonesia is bigger too than in Thailand? In Thailand, stunting 11%, while in Indonesia, there are 21 to 22% in 2023. As you know, in every community services, Pengmas, we have done before, we always said that exclusive breastfeeding will reduce stunting, wasting, less body weight. I want you to explain why does this that? Thank you,
Yeah.
Mr. Febri.
Thank you, Bapak Johnson. I also have a same question but with Bapak Johnson because by this data, general people like me will give an
Big question.
like maybe we can get the information that EBF not a key factor influence stunting incident by this data? So can you make a more explanation about this data? Before you answer your Pak Johnson questions, we go to the third question from Ibu Anggi. Time is yours.
Okay, thank you very much. Am I audible? Okay, thank you very much. I have one question for each speakers. The first, I would like to ask Mrs. Masra. Yeah. Okay.
Okay, Bu Anggi.
Know that in Indonesia we are accustomed to buying medications freely that available on the market, ya kan? Many apotek. Nah, we know that the regulation of drug purchases is still very weak, including for pregnant and breastfeeding mother. So my question is, what might happen if pregnant or breastfeeding mother use medication without consulting a doctor or a pharmacy? Yeah, is that clear, Miss Masra?
Clear, Miss.
Okay, thank you very much. And my second question to Mr. Haripin Paugap, Mr. Haripin Sinaga. Okay, I'm sorry.
Ya, hari pentogap is okay.
Okay.
Togap sengaja.
Okay, sir.
Hati.
We know that it is very interesting, of course, to discuss about the breastfeeding. Yeah, from season 1, we talking about exclusive breastfeeding, ya kan? And it's such a pride for me and another mother. Yeah, if we can provide exclusive breastfeeding for our baby. But however, the reality is that many mothers are unable to provide sufficient breast milk, which result in a high use of formula milk. Yeah. I think you have many research before, and what is the possible reason for a mother's failure to produce enough breast milk to achieve ABF tadi?
Pardon, once again. The last.
The
I can
last
see them.
is what are the possible reasons for a mother to for a mother failure, yeah, to produce enough breast milk to achieve the exclusive breastfeeding, yeah, because we know there are so many mother that cannot do the exclusive breastfeeding, yeah, they cannot produce milk, yeah, sesuai kebutuhan bayi. Okay, is that clearly, Mr. Hari?
Yeah.
Okay, thank you very much.
Thank you for the three questions from audience. Okay, we can go first to Ibu Masrah to answer the question. Time is yours. Ibu Masrah, or we can switch to Bapak Haripin.
Okay.
Okay, Ibu Masrah first.
Thank you for Mr. Febri. First, I want to answer Mrs. Yunis' question. Collaboration between health profession is important in maternal and child health service because interprofessional collaboration is very important. Because maternal and child health care involves many aspects such as medication, nutrition, and clinical monitoring. By working together, doctors, midwives, and pharmacists can ensure that mothers and children receive safe and effective treatment. Pharmacists assess the safety of drug. Doctors provide medical diagnosis and therapy, while midwives monitor the mother's and child condition. This teamwork helps prevent medication errors, improves patient safety, and provides holistic care that focuses on both prevention and treatment. In addition, collaboration increases public trust and help promotes better health outcomes for mother and children. Okay, I think that all. Thank you.
For Ibu Anggi question, Ibu Masrah, directly answer by you.
Oke, for Ibu Anggi. Okay, let me answer your question, Ibu Anggi. If pregnant or breastfeeding mother use medication without consulting a pharmacist or doctors, it can lead to serious risks. Some drugs can cross the placenta or enter breast milk, which may cause harmful effects on the fetus or baby, such as birth defect, growth problems, or toxicity. Without professional guidance, mothers may also take wrong doses or use a combination of medicine. Pharmacists play an important role in ensuring that every drug used is safe, appropriate, and effective for both the mother and child. Therefore, consultation with a pharmacist help prevent side effects, ensure correct drugs use, and protect the baby health. Thank you, Ibu Anggi.
Thank you, Ibu Masrah, for the both question. Yeah. Okay, we go to Bapak Haripin Sinaga to answer the question from both audience.
Okay, firstly for Mr. Johnson, maybe juga Febri tadi punya pertanyaan sama. Before I prepare my presentations, I also thinking about what the causes. We have similar perceptions because when I share my experience, I always say that improvement of breastfeeding, even though alone, we can use it as a guarantee. Sometimes I said, if you can increase 80% ABF, the stunting prevalence should be around 10 to 15. But actually, we should study first from the UNICEF conceptual framework. Breastfeeding is not the first variable to measure the stunting. So we have like educations, and then we have also like complementary feeding, we have environmental and household economy. But the research shows Thailand since 1980s, they have go further than Indonesia. We are behind from Thailand. And the current data said that for the environment or the clean water, the rate 99% in Thailand. They have already performed better in sanitations. This is the sensitivity factor of stunting. While Indonesia, because we have a big countries, regional equity is uneven. The number is about 80%. So this is the important that we should remember, that environment or the better sanitation. And then talking about the surveillance. Okay, tomorrow I will be the presenter in Medan to teach TPG nutrition how to perform surveillance. The problem we have application APP-BGM. You know APP-BGM? Semacam aplikasi untuk gizi. You know, if I ask, how do you manage this? Why the number is like smooth and smooth? You know, every month they can put the number of increasing of weight is about 200 grams every month without weighing the babies. So in Thailand, they have digitally now. We still have manually. So in monitoring, Thailand systematic and digitalized, while Indonesian still manual and uneven across the regions. We're talking about the regions. And also about breastfeeding, MPASI. In Thailand, they have integrated in community-based program. They attach into, even though we have posyandu, even though we have, but sometimes we still find the mothers bring the formula, mix the posyandu, and cadres ignores the situations. Yeah, but in Thailand, they don't bring it to posyandu because cadre should be prevented. But Indonesia, if you go to posyandu, you still find mothers with the bottle of milk with posyandu, and there are many advantages in Thailand, yeah, in talking this. I was in Thailand in 1995. I found that, you know, you can find easily the protein sources in Thailand. You can find it in the market, ya. Maybe I want to say in bahasa seperti misalnya kita mau menemukan jual daging ular ada, daging tikus ada, cangkrik ada. Moose is the best source of protein, but in Indonesia we reject it. Ya, ya,
Gorengan.
ya, gorengan. And for Anggi, I am the facilitator of lactation counselor. Yeah, we have a song, a sing. The size of breast is not determine the number of milk. Ya, payudara kecil, payudara besar sama saja, katakan.
Betul.
Ah,
Correct.
yeah, but the image for Indonesian women, the smaller means that smaller produce of milk. This is the first. But the bonding and how to breastfeed babies normally in Indonesian women, yeah, still low. Even though we have the trained counselor, after training, they never practices in the field. We have a lot of numbers of trained lactations trainer in Indonesia, especially not Sumatra, because I go to some district. And if we ask them how many mothers have you counseled after the training, what they said? No money.
No money,
Huh?
no time.
Yeah, this is the problem. Even though we said this is the most important thing, if you go to the mothers before they deliver, it is the right time to counsel them because the colostrum and how to breastfeed, it is the important thing for the mothers. But this is the real big problem. So for us as a lecturer, we have many tasks to do. Yeah, especially for midwifery and for nurse, especially also for me as a trainer of lactation women or lactation staff. Yeah. I think this is the answer for my friends, for my colleagues, Febri, Angie, and Johnsons. Thank
Excuse
you.
Mm.
May I add some question, Mr. Haripin? The things that I've asked is that a mother who wants to do the ABF, but she can provide the milk.
Mm.
Jadi ASI yang dihasilkan itu tidak sesuai dengan keinginan sehingga anak merasa kurang gitu kan. Jadi ibu biasanya normally the mother will give the baby bottle. Jadi biar bayinya itu bisa kenyang. Okay, that's the reality that I've been found in the public.
Mhm.
Ya, jadi
So the perception, yeah.
yeah,
Mm.
no, that's not about the size
Mm.
of the breastfeeding,
Mm.
but it is about the adequate of the milk. Yeah, jadi
Yeah.
even though the mother has tried many methods like consuming vitamins, jamu, like endorphin message that we've been told her that, but the milk still doesn't come.
Produce. Mm.
She can't still about she can yeah, she can produce the milk adequate. Yeah, maybe that's one of the biggest challenge I think for the ABF that's become failure, sir. Karena banyak memang ibu-ibu itu yang tidak mampu dia. Jadi we don't know apa sih what's the problem ya, kita nggak tahu karena the apa namanya research about that tidak terlalu mendalam gitu. Jadi tentang itu tidak terlalu mendalam. Padahal dari awal itu ibunya sudah setuju, sudah bahagia, ingin menyusui, semangat ibunya, tapi milk yang dihasilkan itu tidak adekuat gitu. Jadi
Okay.
kenyataannya banyak banyak seperti itu,
Yeah.
Mr. Arifin.
Okay, according to the research, maybe it could be 1 to 2% only, significantly or scientifically, yeah. If there is a preparations before delivery, and then the mothers know how to firstly breastfeed, and the position and bonding and the circulation, it like end milk and fore milk, they understand, and then it should be breastfed at least 20 minutes for one session, and the next sessions 20 minutes. It should be produced automatically, the milk. I think it is. That's why I said in my presentation, the breastfeeding is the beautiful biological design. This
Yeah.
very unique.
Yes, I agree with you. Yeah, I agree. As I say that it is a pride for us as women if we
Yeah.
do the ABF. Maybe you can continue research about that because not only in first child, also there are women who can do the ABF with the second or the third child. That's okay. Maybe that's for me. Thank you very much.
Thank you.
Thank you, Bapak Haripin. Thank you, Ibu Masra. In line with your answer, Bapak Haripin, I do agree with you as a microbiologist. I believe that what's inside of our intestine, our good in our intestine, consistently influence to our phenotype and physical characteristic. We are talking about sanitation or water quality. We also focus only on the wash, right? Sanitation
Water
or
sanitation, hygiene.
water sanitation and hygiene. However, there are so many research focus only on wash, not about not finding a root of this problem. As a microbiologist, I believe that the problem is not about only about hygiene, sanitation, or water, or about nutrition. There is more technical issue on that. As a root of the problem, that's a microbiota of our intestine. So this is the big gap of our research, especially in Poltekkes. Every Poltekkes in Indonesia, I didn't find any research related to the profile of microbiota in our intestine. That's the maybe like in line with your answer to what makes different between the data from Indonesia and Thailand. That's maybe one of the
reason.
one of the reason. Thank you, Mr. Haripin. Now we have the last question from Ibu Tiur.
Oh, still.
Yeah, still have. This is maybe this will be the last question, yeah, the audience, because it's almost 4:30.
Oh.
Okay, Ibu
Yeah.
Tiur.
Yeah.
Halo.
Thank you very much for Mr. February. Okay, I want to.
I not see you, Tiur. I just
Yeah.
also see your raised hand, but no faces. Is it?
Oh yeah, yeah. Oh yeah. The first, I'm sorry because my computer is having problems, so I can't show my my face. Yeah. This our discuss is very interesting. Mr. Haripin,
Oh yeah.
you explain how to care for babies regarding breastfeeding. However, in fact, more babies receive formula milk than are exclusively breastfed. I agree that breastfeeding is not the only factor influencing a child's slow growth, as environmental and behavioral factors are need to be considered. The issue of formula milk is interesting in light of the issue of microplastic entering babies' bodies through bottle. Receipts show that microplastic can increase the risk of health problem because microplastic can cause a decrease in good microbiota and intestinal inflammation. What are your suggestions for reducing the influx of microplastic through formula bottles? Thank you.
Okay, frankly, that maybe this is not so related to my field. Maybe Febri can add my answer. Yeah, like I said, that the breastfeeding process, this is the key of biological means that like what not only talking about nutrient in there. Yeah. So what you said, I agree with you, but I cannot explain more because as I understand, the circulations in the producing milk, it brings a lot of organ in our body, especially for women. So this is the new things that maybe this is we can start how to move the issue of studying breastfeeding with what you are just saying to me. So I think I agree with you. Maybe as a pharmacology. Febri in.
Okay. Uh, Actually, I cannot add the add the information related to the question of Ibu Tiur, but like what I say before that, if we are talking about stunting, there's so many factors that influence stunting incident, especially in Indonesia. Many characters, many cultures, many things about Indonesia is so different between Thailand and Indonesia, but we can understand that Thailand have a good sanitation, like Bapak Haripin said before, that yeah, maybe it can take a bigger percentage to influence stunting incident, but we cannot make sure that what is the characteristic of the bad sanitation? Is it about microbiology? Is it about microplastic? We cannot find it, so we have to do a research to find this to find the data to prove that the sanitation is the key important things that influence in stunting. That may be from me, but as a microbiologist, I say that the microbiologist in our gut, that's so so make a biggest percentage in influence stunting, because that's make a biofilm in our intestine, and then the bad pathogen make biofilm, and then biofilm will reduce the ability of our intestine to
Absorption.
absorb nutrition intake of in child body gitu.
In effect, the
That's it.
absorption process in the
Yes,
body.
that's affected to absorption. That's from microbiologist. Thank you so much, Mr. Haripin. Thank you so much, Ibu Masra, for join us in the fourth conference of Polytechnic Medan. Ladies and gentlemen, that's all for that's all our third session today in this conference. We sincerely thank you for all speaker, Ibu Dr. Fitri Widyaningsih, Miss Leontine Baker, Ibu Masra, Bapak Dr. Haripin Togapsinaga, to their valuable time and contribution to this conference. If I can conclude in one sentence, this conference has a highlight the importance of collaboration, innovation, and evidence-based practice in improving global health outcomes and strengthening our collective commitment to healthier future. So thank you so much for all participants for your active participation and attention. And thank you so much, and we can meet in another conference of Polytechnic Medan. Thank you, Miss Leo. Thank you, Ibu Masra. Thank you, Bapak Haripin.
Thank you, Leo.
Thank you. Okay, thank you so much. I'm Febri Sembiring. Thank you for your attention. I'm signing off as a moderator in this conference. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi taala.
Thank you, Pak Febri, for guiding this second session. Ladies and gentlemen, thank you very much for being our participants, and especially for our speakers today, for Dr. Fitri, Miss Leontine Becker from WHO, and thank you for Bu Masra and also Pak Haripin Togapsinaga. Yep. Thank you for your great material today that have delivered to all of us in Medan Health Polytechnic. Your insight and expertise has been truly inspiring and invaluable to our event. We deeply appreciate the time and effort you took to share your knowledge with us. So thank you very much, Ibu dan Bapak, and also Miss Leo from WHO. See you again in another good event of Medan Health Polytechnic. Ladies and gentlemen, we have reached the conclusion of today's conference. We hope the discussion and also all the insight materials shared will inspire continued collaboration and innovation in maternal and child health services worldwide, especially in Indonesia. See you tomorrow at the oral presentation session. Of course, I invite all the presenter that have been uploaded all the presentation. We'll have our session at 8 a.m. And so we will have a review and discussion session in all panels. Thank you for your active participation, ladies and gentlemen. We wish you have a happy day and continued success in your work. Good afternoon and stay healthy and also stay happy. Bye-bye. See you again, ladies and gentlemen. Thank you very much.
Thank you very much, Mrs. Hannah.